So good evening everyone. Am I visible and audible? हाँ हाँ स्ट्रीमिंग शुरू किया. हाँ हेलो हेलो. अब ठीक है. अब ठीक है. मैं नहीं दिख रहा. नहीं मैं नहीं दिख रहा. मैं नहीं दिख रहा स्क्रीन पे. मैं स्क्रीन पे नहीं दिख रहा हूँ. ठीक है. हाँ स्टार्ट कर दी स्ट्रीमिंग. Good evening everyone. If I'm visible and audible, please give me a thumbs up, guys. Okay, so I can listen to myself, but I haven't got. Okay, hello, Dr. Rashmi. I got a hello. Right. So let's start with the session. Any doubts? Dr. Ma Shedits. Good names here. Chalo, I'm just keeping the phone at the side. I will see the messages that you people are texting. Hi, doctor. Hi, Dr. Ma Shedits, Dr. Rashmi. Let's start without wasting any more time. We'll straight away go to the session. Any questions and doubts, you can ask me directly. I'll try to solve them to the best of my knowledge. Let me start with straight away with anesthesia. Okay. There we go. All right. So let me introduce myself to you. My name is Dr. Vinish. Presently, I'm the head of the department and the Associate Director of Anesthesia. I'm working with the Fortis Lapham Hospital in New Delhi, GK2. I'm also a faculty with PW MedEd teaching anesthesia. I've been teaching anesthesia for 14 years now. Okay, let me start straight away with the first question that we're doing. What we are covering here is INI-CET image-based questions. I'm trying to cover up all the questions which are there, which have been asked recently, and all that we are targeting are previous year's questions, previous year's topics, and some questions I have changed based on that. And basically what doctor says, sir, everyone knows you. Acha, I didn't know that. Anyways, let's start with the image-based question. First question, I prefer that if you people can answer me. It's always better to have an interactive session. If we have an interactive session, we will like it. Okay. Dr. Ma Shedit says it for FMG. Of course, Dr. Ma Shedit, of course. All these questions are important for FMGE also. Yes, all for FMGE as well as NEET PG as well as INI-CET. It's important for all the questions. Basically, I'm covering up all the image-based questions from all the topics of anesthesia. And I think most of the image-based questions I will have covered with the discussion that we are having. Right? So questions are fairly simple. We'll not go into too much details, but we'll just see. Correct. So answer given here is correct. This is Malampatti grading. This is not 𝐒𝐿𝐴𝐻. This is not ASA scoring or AHA grading. Remember, 𝐒𝐿𝐴𝐻 grading is something which you call as a laryngoscopic grading. When you use a laryngoscope to see the vocal cords, so this is normally used in ENT or anesthesia, whatever you say. So laryngoscopic grading is basically what is called 𝐒𝐿𝐴𝐻 grading. Laryngoscope grading of the vocal cords. So whether vocal cords are seen or not seen. So this is also called as laryngoscope grading, right? ASA scoring is nothing but the ASA grade 1 and 2. This basically tells you the physical status of the patient. Physical status or the medical status of the patient. And Malampatti grading is basically for difficult airway assessment. Okay, this is for difficult airway assessment, basically for difficult intubation assessment, right? It is for that. Next, let's go to the next one. So this is about the first question. Similarly, based on Malampatti, remember Malampatti is one of the most important questions in any exam that you're giving, NEET PG, INI-CET or FMG. Next is in the adjoining image, the Malampatti score is it grade 1, is it grade 2, is it grade 3 or grade 4? Okay, simple questions come from anesthesia, but you just have to know which topic they've come from and just have to be aware of them in the exam, right? So simple question over here, what you can see, you can't see anything because the whole point about Malampatti is that you're supposed to try to see the uvula, right? That one structure which helps you. Correct. The answer here is Malampatti grade 4. because here you can't see anything about the uvula. All you can see is the hard palate. So Malampatti classification basically tells you about the posterior pharyngeal structures. The first thing is, how do you do Malampatti? Open the mouth, extend the tongue, do not phonate. So remember, one has to open the mouth, extend the tongue, and do not phonate. Okay, do not phonate means don't make any noise. You're not supposed to say ah. And we are supposed to look at the posterior pharyngeal structures, which are over here. These are posterior pharyngeal structures. So therefore, in the posterior pharyngeal structures, the first structure that you see here is the uvula. So Malampatti 1, the uvula is seen completely. Then here are the tonsillar pillars. So if you can see the tonsillar pillars, again completely seen. Fauces completely seen. Soft palate and hard palate are completely seen. Now, if you cut it like this from here and the tip of the uvula is not seen, you will realize in Malampatti 2, uvula is seen only half. And you will realize these tonsillar pillars and fauces are again seen half. So pillars are half, fauces are half, but soft palate, hard palate are seen. In Malampatti 3, you can see just this base of the uvula. The rest of the, uvula is not seen and the tonsillar pillars are not seen. So therefore, here uvula, only the base is seen. Base of the uvula is seen. All right. Pillars are not seen, fauces are not seen, but soft palate, hard palate are seen. In Malampatti 4, which was the question over here, nothing is seen except for hard palate. The point is, when you do Malampatti, they say it's a reflection of the glottic opening. It tells you about the laryngoscopic grading. It is indirectly related to the 𝐒𝐿 grading, right? So this 𝐒𝐿 grading, the Malampatti indirectly tells you about the laryngoscope grade. That in the OPD, if you can see the uvula, on the pre-anesthetic checkup, then in the OT, I'll be able to see the vocal cords. And if I can't see the uvula in the OPD basis, I will not be able to see the vocal cords. That's why it becomes a difficult intubation. That's why Malampatti 3 and Malampatti 4 are called difficult intubation, because if I don't see the uvula, I will not be able to see the vocal cords on laryngoscopy. And this is our 𝐒𝐿 grading. This what you see is what is 𝐒𝐿 grade. Again, this can be image-based question, 𝐒𝐿 grade or the laryngoscope grade that I was discussing about. Malampatti 1 and 2, I expect the vocal cords to be seen. Malampatti 3 and 4, I expect vocal cords not to be seen. So therefore, Malampatti 1 and 2 relatively become easy intubation, easy mask ventilation. On the other hand, Malampatti 3 and 4 become difficult. That's an important question. Dr. Anna says, should FMG students attend it? Of course you should, yeah. It's the revision of all the points, all the images from anesthesia, and discussing everything. It's only the tongue we decide for all the structures and size. It's not about the tongue at all. You are seeing the position of the tongue in relation to the posterior pharyngeal structures. Remember, Malampatti classification. Yes, you are protruding the tongue, but on protrusion of the tongue, you are supposed to see these structures. These structures basically are the posterior pharyngeal structures. So you are seeing the position of the tongue, right? But it's not about the tongue in general. It's what do you see on the posterior pharynx that is important. And these structures which you see, uvula, tonsillar pillars, fauces, soft palate and hard palate, these are posterior pharyngeal structures. And that is why this is what you're supposed to see. I hope this point is clear. Dr. 𝐒𝐿𝐿. Okay. So मेरे को नाम नहीं पता Dr. 𝐒𝐿𝐿 का, but that's the point. Okay. So this is your posterior pharynx that you see. Next question. All right. So this was Malampatti, important question as I told you. Right. Next. So which of the following gas is used by the surgeon for insufflation during laparoscopic hernia surgery? Right. There are 4 images that you have. You have to choose the answer based on the image. So this covers up all the questions, right? All the points of the cylinders which are asked in the exam. Yes, guys. So is it A, is it B, is it C, or is it D? So you have to know the color of the cylinder to understand what has been used. Okay. Dr. 𝐒𝐿𝐿 says C. Correct. C is what is used. Absolutely correct. ठीक है? क्योंकि ये है carbon dioxide cylinder. This is Dr. You can say Dr. Vivek Tiwari says C. Correct. All of you are correct. Good point. Everyone is knowing then. Right. It was very easy for me to say which of the following is used for oxygen. All of you know what is oxygen. Hence, I wanted to ask something different. And C is what is carbon dioxide. Okay. So this is what is used for insufflation during laparoscopic hernia surgery. For laparoscopy, this is the gas which is insufflated, and that is why you're supposed to know these colors. Right. The first gas which you see, all of you already know, it's blue colored nitrous oxide, and for Nila, and right, nitrous oxide. The black and white is oxygen. The next one is carbon dioxide. And if you see the next one, the last one that you see is blue in color, and plus you have blue plus white shoulder. This is a mixture of both oxygen and nitrous. This is called entonox. So remember, the colors are very important. When you speak of anesthesia machine, guys, remember there are 3-4 points which are important from image-based questions point of view. First is the cylinder. You are supposed to know the color of the cylinder and the pin index numbers. These are important. Then they would ask you something, not rarely, but once it has been asked regarding the color of the knobs. So the color of these knobs become important, right? And after that, what becomes important is regarding these vaporizers, right? And finally, there are the pipelines and breathing circuits. These are the 5 places where they ask questions in anesthesia machine, whether it is for INI-CET, FMG, or NEET PG. So the cylinder colors and pin index you're supposed to know. The color of these knobs you're supposed to know. Here are the vaporizers which you need to know. After that, pipelines. So there is another point called pipelines, and last is these breathing circuits. So these are 5 important questions which come from anesthesia machine, which you should be aware of. Speaking about the color of cylinders, so everyone already knows that. I'll just write down in short. Remember the cylinder of air. Air is the first one which you see, and this is basically gray body with black and white shoulder, right? With black and white shoulder. What is shoulder? Shoulder is this point. The next is oxygen, which is black body with white shoulder, right? Shoulder I'm writing just as S, okay? White shoulder. Then you have the next one, nitrous oxide, which is completely blue in color, right? After that you have Entonox, right? And Entonox being a combination of oxygen and nitrous, it's a mixed color. So you will find blue body with blue and white shoulder, or blue body with white shoulder, right? And the last one, which is important, which I just asked you, was carbon dioxide gray in color, right? These colors are important. Dr. Marsh Edit says, what about air? Bol diya na, gray with black and white shoulder. Don't worry, I'll cover up all the questions. That's what I said. Even for FMG students, even for NEET PG, attend the session. It's the same thing. I'm discussing all the image-based questions. They are common for all of them, right? Yes, what happens in INI-CET, the level of questions become difficult when they're asking you specific questions regarding ventilator, or when they ask you questions regarding arterial blood gas, analysis. In FMGE, it's be slightly, they won't ask you the ventilator settings directly, but in INI-CET, they'll ask. But image-based remains equal for all of them, right? So this is about the color of cylinders. Another important point is pin index. What is pin index, guys? See, pin index is what prevents the wrong attachment of cylinder. If I want one day to put the nitrous oxide cylinder here and oxygen cylinder here, I can't do it because there is pin index safety system which prevents it from doing so. So you have pins coming out of anesthesia machine, you have corresponding holes on the cylinder, and this is what is called as pin index safety system, right? So each gas has been given a separate number. So they made numbers like this: 1, 2, 3, 4, 5, 6, and 7. A same thing has been put like this: 6, 5, 4, 3, 2, 1, and 7. So what will happen? The anesthesia machine is going to have one pin. For example, 1 and 5. The corresponding is present on the cylinder 1 and 5. So what happens? They fit onto each other, right? 1, 5 gets fit onto it. So these pin index numbers are again very important. As you will see, air. Remember air, this is the pin number that you see. Air is basically 1, 5. Oxygen is what you see, 2, 2, 5. Nitrous is basically 3, 5. Entonox is the only one. Remember, the longest name that you have, Entonox, is number 7, because we write oxygen as O2, nitrous as N2O, carbon dioxide as CO2. Like in Entonox is written as 7, right? So Entonox has the number 7, and wherever you get the number 6, so 1, 6, and 2, 6 is for carbon dioxide. So this is basically 1, 5, this is 2, 5, this is 3, 5, this is 7, this is 1, 6, right? So the pins come out of the anesthesia machine and the corresponding pin receivers are on the cylinder, right? Clear? So you have pin index safety system. We are done with that also. So pins come out of the anesthesia machine over here and the corresponding holes are on the cylinder, right? So we have finished of the colors, we have finished of the pin index. Next, I told you about the knob. Can you see if oxygen knob is here, then here is going to, sorry, oxygen cylinder is here, then the cylinder air will pass like this, and from the nitrous oxide, the cylinder air will pass like, I mean the gas is going to pass like this. So here you have the knob of oxygen, here you have the knob of nitrous oxide. Remember, oxygen knob is white in color, it has broad serration. So what knob I'm talking about? This one, this knob which you see here. So oxygen is white in color, it has broad serrations or broad grooves. On the other hand, you will find nitrous oxide over here, right? From the anesthesia machine that we see, oxygen goes from here, nitrous goes from there. And nitrous is basically everywhere you find blue in color, and it has comparatively thin serrations, right? So this was about the norms. Next question. Which of the following vaporizer used for inhalational anesthesia needs supplied heat and an additional electrical supply? A similar question was asked in FMGE. Similar question has been asked in NEET PG as well as in INI-CET. They have been more specific, but here I've included all the, it's not been asked like this ever. I changed the question in such a way that we can have a discussion on that as well. So I just put all the 4 vaporizers and I would want you to answer this question. Which of the following vaporizer used for inhalational anesthesia needs supplied heat and an additional electrical supply? Okay, Dr. Ma Shedit says B. Or koi, any other answer? First, you need to identify the vaporizer and then you need to know the property. Anyone else? Any other answer? Dr. Ma Shedit thoda sa galat hai. Okay, one more option, one more choice. Agar B nahi hai to kya answer? If not B, then what is the answer? This has been asked in FMGE as an image-based question, but there they had asked you like this. In FMGE January 2024, this question is FMGE January 2024, where they gave you image of this and they had asked you which of the following this vaporizer, which is this vaporizer? This was the question asked in FMGE, right? And here they gave you 4 options. They had given halothane, isoflurane, desflurane, and sevoflurane, right? So the correct answer for this question is option D, and D is which is desflurane. This was the question asked in the exam also. If you will see the desflurane, correct. Tech 6, absolutely correct. Why? Why? Because can you see this looks different from all other types of vaporizer. I'm showing it here only. Can you see this? In terms of structure, this, the first one that you see is for sevoflurane. The next one that you see is isoflurane. The next is halothane. And the last one that you see is desflurane. So these are the vaporizers that we have. Right, so sevoflurane is yellow in color, isoflurane is purple in color, this is red in color, and desflurane is blue in color. Forget the colors, but when it comes to structure, you'll find the first 3 have a structure that is similar, but the 4th one which you see, the structure is different. It's slightly bigger, right? It's slightly bigger, it's slightly thicker. At the same time, this has an electrical supply, right? It needs electrical supply because remember, when we speak of desflurane has the highest saturated vapor pressure. Desflurane basically boils at 23 degrees or room temperature. Because it boils at room temperature, it needs a special vaporizer, and this special vaporizer is electrically heated. Compared to others, this is the only one which needs a special vaporizer, and this special vaporizer is electrically heated. Right? Dr. Vivek says D. Correct, guys, correct. All of you, Dr. Prajwal and Dr. Vivek, correct, electrically heated, right? This is the reason why we have a specific special vaporizer used for desflurane. It boils at 23 degree, highest saturated vapor pressure, and the color is blue. So here the color is also important, and the reason why desflurane has a special vaporizer, that is important. And this is not an old question. This is 2024 January FMGE question, right? This image has been asked in the exam. Right, but they had not asked like this. I've just changed the question, right? I'll just change it slightly so that we can have a discussion on all. One more point, remember, sevoflurane is yellow, that we have seen. Isoflurane is purple, that we have already seen. Red is halothane is red in color, and desflurane is what you see, blue in color, right? There's one more that you need to remember, that is enflurane, which is orange in color, but this has rarely been asked in the exam. But just remember, enflurane vaporizer is orange, okay? Enflurane vaporizer. Next question, right? So these are the vaporizers that we discussed. Now, apart from vaporizers, another important point I was telling is pipeline. So anesthesia machine has these pipelines also, and pipelines are spread all over the hospital. So these pipelines also have color coding. So as we had, pin index safety system, which prevented the wrong attachment of cylinders, can you see this? This is what is called pin index safety system. So pin index safety system, this prevents the wrong attachment of cylinder. Okay, this we already know. Similarly, you have diametric index safety system, which prevents the wrong attachment of pipelines. It is not about cylinders. So pin index safety system, remember, this is for cylinders. This is not for pipeline. A lot of people get confused. Remember P for pin index and remember P for pipeline. No, it doesn't work here. It's not correct here. Pin index is for cylinder. Remember it as PC. Okay. Pin index is for cylinders. On the other hand, Before I could answer, all of you have given the correct answer. White oxygen, Dr. Prajwal specifically. Blue nitrogen. Nahi, blue nitrogen is nitrous. Spelling mistake ho gaya. Air is black. Correct. So this is what is called as diametric index safety system. It is based on diameters. It prevents the wrong attachment of pipeline. You can't put this one here. You can't put this one there. Remember, this point is called diametric index safety system. Okay? Diametric index. These are easy questions, guys. Don't make mistake in anesthesia. Okay. Other subject, anesthesia is something which helps you cover for other subjects. So please don't make mistakes in anesthesia. We get simple questions. You're just supposed to be aware of them. So diametric index safety system. This is for pipelines. This is for pipelines. It prevents the wrong attachment of pipelines. Correctly pointed out by all of you that oxygen is always white in color. The first one which you see, nitrous is always blue in color, right? The next one which you see, air, which is black in color, right? And the last one that you see is vacuum, which is yellow in color. Apart from that, now we have finished off the pipelines also, and I told you the last thing about the anesthesia machine, what is important is breathing circuits. So breathing circuits are basically of three types: closed circuit, open circuit, and semi-open, semi-closed. The maximum questions come on the semi-open, semi-closed, which are Mapleson circuits. So the one which you see on the image over here, this one is a Mapleson circuit. So they ask you questions about this, which is Mapleson circuit. So normal classification that you will find. So routinely we have breathing circuits, which are classified into three types. You may have open circuits, which are not used for anesthesia anymore. Second is called semi-closed, but you can also call it semi-open, you know. So at your level, remember, semi-open and semi-closed are the same. There is slight difference between them. And the last one is closed. Closed is basically the circle system which contains soda line. Remember this point. It contains soda line, and here rebreathing is present. On the other hand, here there is no rebreathing, here there is no rebreathing. Okay, that rebreathing is absent in here and rebreathing is also absent here. It's present in closed circuit. All right. So when we speak about the circuits, guys, another important question that come on Mapleson circuits. So semi-open ka example. Semi-open ka example. This is Mapleson circuit. Mapleson circuits are between Mapleson A to F. So they ask you in exam what is used where. Okay, normally they have not asked regarding image ever. Normally they have not asked, but yes, you're supposed to know the images also. So you will ask me, sir, should I remember everything? No, don't remember B, C, and E. That is okay. You need to basically remember Mapleson A, Mapleson D, and Mapleson F. Most of the questions come from here only. Mapleson A, D, and F. Mapleson A, remember, is called McGill circuit or Lack circuit. This is used for a spontaneously breathing adult. Remember, this is used in adult. Right? At the same time, Mapleson D, it is called Bain circuit, and this is used for IPPV or controlled ventilation in adult. So there must be something for pediatric patient also, right? So whether spontaneous or IPPV, normally the most common use for pediatric is Mapleson F, which is called Jackson-Rees circuit. Right? And this is used for pediatric patient. These are the only three you need to remember. E and F for pediatrics, A and D in adults, says Dr. Marshall. Correct, absolutely correct, guys. But ये याद करने की जरूरत है. Mapleson C, actually, if you will see na, Mapleson E, it is not used for basically pediatrics. This is basically for neonates, right? But now and used in ICU also. But forget Mapleson E. Normally they won't ask you Mapleson E. It is used for a neonatal ventilation and it is used in ICU. These are the two uses, right? And remember, when you speak of pediatric patient for Mapleson F, important point is that Jackson-Rees circuit or Mapleson F that we are talking about, which is used for pediatric patients. It is used for pediatric patients less than 6 years of age and less than 20 kg. Again, it's an important point. And if the baby is more than that, then you are supposed to use Mapleson D or Bain circuit. That is important. And that is why Bain circuit is the most common used circuit. The most common is Mapleson D. It is used for adult, pediatric, everywhere, but pediatric means more than 6 years of age and more than 20 kg. Dr. Prajwal says, no corrugated tube, IRS, TPs. हाँ, वो सब correct है, but उतने depth में नहीं जा रहा हूँ यार, फटाफट खत्म कर रहा हूँ points. Okay. So next question. Identify the adjoining device. All right. Identify the adjoining device. So you have neuromuscular monitor, bispectral index, temperature monitor, or capnography. Correctly said, correct. Correctly pointed out. The answer here is B, bispectral index. How did you understand it is bispectral index? So I understood it's bispectral index by the presence of these electrodes on the forehead. So whenever you see electrodes on the forehead, basically it is trying to analyze the brain activity. So this is what is called bispectral index. Here you have electrodes on the forehead. Basically what it is doing is bispectral index is based on electroencephalogram, EEG, or it is basically measuring the brain activity of the patient. So basically it is measuring that based on EEG activity, you know if the patient is awake, if the patient is sleeping, if the patient is conscious, unconscious, or dead. It's basically measuring the brain activity. So it will give you a number. As you can see, it has given a number. So you get a number between 100 and 0. Remember, the number 100 means the patient is awake, fully awake. So as you can see, 91 means the patient is awake. A number 0 means patient is in coma, or this means flat line EEG or coma. Right. A value of 40 to 60 is set for general anesthesia. A 60 to 80 is set for sedation. Right. So this helps you to maintain the depth of anesthesia. For example, if during surgery you get a value 91, it means the patient is awake during surgery. He is conscious during surgery, which is wrong. And therefore, what you need to do is you have to increase the anesthesia at that point of time. So that is why it is said that bispectral index, this helps you to maintain the depth of anesthesia monitor. And that is the reason it is also called as depth of anesthesia monitoring. It's also called as depth of anesthesia monitoring. Correct. Well prepared, all of you. Good. I think most of you, all of you are giving correct answers. It prevents the complications. It helps you to titrate the medicines. You can give more, you can reduce less. So it tells you the depth of anesthesia. But remember, it does not tell you why it has happened. It just tells you the reason that the number is 91. It does not give you the reason. Is the reason because of some brain injury? Is the reason because of some pneumonia? Is it a reason because of some patient being off to sleep or someone has hit on the head, trauma? No, it does not give you the reason. It does not give you the reason why the value is 91. It does not give you the reason why the value is 40. It does not give you the reason why the value is 0. It just lets you know whether the brain activity is present, not present, or how much present. It does not give you the reason of why the brain activity is less or more. Remember this. Dr. Prajwal says, sir, please explain train of 4 rule once. Okay. Once I'm discussing that, I'll come there and discuss train of 4 also. Okay, done. Sure. Right? We'll do that. So this was, I'll remember when I'm coming to that point, I'll discuss it. Next one, which of the following is measured by the device shown in the image? Right? Amount of inspired oxygen, oxygen content of the blood, partial pressure of oxygen, or perfusion index. ठीक है. देखो नॉर्मली इस पे इजी क्वेश्चन आता है, मैंने थोड़ा आगे पीछे किया है. सिंपल, इट कम्स इजी, बट आई हैव डॉक्टर सुषमा हैज गिवन आंसर. सब लोग ने सी मार्क किया, क्यों? यही तो पॉइंट है यार, इसी में तुम लोग कंफ्यूज होते हो. नो, इट्स नॉट द आंसर. सी इज नॉट द आंसर. That is why you twist a question. This is where the problem happens. If I had given the last option, what I have changed, what the same question has been asked in exam, the same question. What I have changed is, instead of this, the exam question was what has saturation of oxygen. If I had given this, saturation of oxygen, all of you would have given the correct answer. Had I mentioned that, the answer is not that. It tells you perfusion index. Answer is D. It is perfusion index. First of all, this is pulse oximeter. What is the device that you see? Pulse oximeter, right? We know pulse oximeter. All of you know what a pulse, all of you have it at home also. During COVID, everyone has used it. You can see, in fact, the points also over here. If you can see the pulse oximeter, can you see this? It is giving you this, which is the saturation. This is what the point was. Next, you get to see the heart rate, right? Based on that, you can get to know the arrhythmias. But can you see this plethysmography graph? This tells you the peripheral perfusion. It tells you the volume status. And you must have seen, अगर घर पे भी किसी के पास pulse oximeter है, if you have it at home, you will see pulse oximeter has something else written, PI, and that is called perfusion index. Yes, playing with words. Exactly, guys. Last time FMG exam mein, that was the problem. Here again, it's playing with words. It's the same question which has been asked in the exam. I just changed one option. Yeah, as I said, I'm discussing PYQ and PYT. Na? Yes, same question I exam mein, just one point I have changed, and the one change was I did not write saturation. What was asked in the exam was not perfusion index. They had asked you saturation. Had I given that option, all of you would have given correct answer. Forget. Now, to think about it, remember, amount of inspired oxygen, you will never get it. So no one gave a correct answer over here, which is correct. You people got confused between B and C. Oxygen content of the blood and partial pressure. Remember, these two you get to know only by the arterial blood gas, ABG. You will not get to know from the pulse oximeter. So pulse oximeter gives you four things. The pulse oximeter first tells you SpO2, saturation. How does it tell you saturation? Remember, pulse oximeter has a light which is passing from here, and the light passes through the blood vessel, right? This blood vessel has oxygenated hemoglobin and deoxygenated hemoglobin. So the light will pass through it. At one point you have oxygenated hemoglobin, other point you have deoxygenated hemoglobin, right? Oxygenated and deoxygenated. So light absorbs through it, and based on that, the difference between them, it calculates and lets you know the saturation. And normal saturation should be more than 91%, because it is based on this pulsatile blood flow to the periphery, which is going. It tells you about the heart rate also, or the pulse rate of the patient. Based on that, you come to know the arrhythmias, right? And then, because this perfusion is happening over here, right, it gives you an indication of the perfusion, which is called as perfusion index. The third thing which you see is perfusion index. And guys, all of you must have seen in every pulse oximeter, whether at home also, you must have seen a graph which comes like this, which is seen here also. Na? Can you see this? Ye dekho na? You can see a graph here also. You can see this graph here also. Every pulse oximeter will show you this graph. Can you see this? This graph. This is what is seen. And that is what is called as plethysmography graph. Plethysmography waveform. It's called plethysmography waveform. So these are the four things which you, and this tells you the volume status. Plethysmography waveform. I'll not go into too much details of things over here, but just remember, you get to know the SpO2, the heart rate, the perfusion index, and plethysmography waveform. When do you get a wrong readings? Simple. You will get a wrong readings if something interferes with the light, like nail polish, lot of light in the room, or anything creating problem with the light transmission. Second thing, you may get a problem with dysfunctional hemoglobin when the hemoglobin is damaged, methemoglobinemia, carboxyhemoglobin, and any problem leading to a difficulty in blood supply, right? Anything that causes vasoconstriction, anything like Raynaud's disease, even in that peripheral vascular diseases, you will get a wrong reading, right? Or use of vasoconstrictor drugs, shivering, hypotension, hypothermia, anything that affects the points over there, the blood supply is going to give you a wrong reading, right? So this is inaccurate reading. And remember, pulse oximeter is an important monitor. It's a very important monitor that is asked in the exam. Simple monitor, don't make mistakes. Pulse oximeter. Next one. The image given below shows neuromuscular monitoring of a patient during anesthesia. Which of the following is being used for this monitoring? Okay, median nerve, ulnar nerve, metacarpal, radial nerve. Same question has been asked in INI-CET. The same question has been asked in FMGE, and it has been asked as an image-based question. Even in NEET PG, but without image-based, they've asked the same question. All right, simple question. Yes, all of you have given a correct answer. This is ulnar nerve. Okay, so this is basically neuromuscular monitoring of the patient during anesthesia. What is it doing? It is monitoring the neuromuscular junction, right? It is monitoring the neuromuscular function. So Dr. Prajwal had asked me regarding TOF, train of 4. I'll discuss it over here. So what is train of 4 and what happens and what is about this monitor? So this monitor basically measures the neuromuscular function. Right? What is neuromuscular function? This monitor, neuromuscular monitor, it is basically monitoring the neuromuscular junction, right? And the function associated with that. So neuromuscular function. Basically, it's monitoring the muscle paralysis, whether the muscles are paralyzed or not paralyzed. It tries to measure that, right? It measures the neuromuscular junction and the function. Just like bispectral index told you about consciousness, this tells you about the paralysis. So if you want to see if the muscles are paralyzed or not, what do? I stimulate the ulnar nerve, 1, 2, I can give one stimulus. If I give one stimulus over here and the muscles are not paralyzed, I will get a response over here, right? If I give a stimulus over here, muscles are paralyzed, I will not get a response over here. If the muscles are partially paralyzed, I give a stimulus, I will get half response over here. and that is what is seen on the neuromuscular. So therefore, what we normally do is instead of giving one stimulus, we normally give 4 stimuli. So the normal stimuli is not single stimulus, but 4 stimuli, 1, 2, 3, and 4. We give 4 stimuli from the neuromuscular monitor. Each stimulus is of 2 hertz. It is given in a span of 2 seconds. Therefore, every stimulus comes at 0.5 seconds. Every point is an MCQ question. Okay. Train of 4. So what I'm discussing is train of 4. This is what is called as the train of 4 mode. So what happens is in train of 4 mode, I'm giving 4 stimuli, where normally this is the most common used, right? Ulnar nerve. And where are you seeing the response? The most common muscle corresponding is the adductor pollicis muscle. Adductor pollicis muscle is where I'm seeing the response. This is the most common muscle used. Remember, apart from ulnar nerve, more important, many books have mentioned the ideal is not the ulnar nerve, but the facial nerve. Many times, many books have mentioned facial nerve to be the ideal. But yes, the most common used is the ulnar nerve. Okay, so most common is ulnar nerve, but ideal is facial. So as I was saying, you're trying to see the response in the muscle, which is adductor pollicis muscle, by the movement of the thumb. And if there is a complete paralysis, whatever stimulus you give, there is no response. If there is no paralysis and I give 4 stimuli, I'm going to get 4 responses. 1, 2, 3, and 4. This is my normal response if there is no paralysis. What stimulus you gave, the same response you got. Complete, we don't get anything. If there's partial, in that case, what will happen is, if it is with a non-depolarizing, you will get to see 1, 2, 3, and 4. You don't need to know why this happens. It's to do with the amount of acetylcholine which gets released, but it is postgraduate level. You are not supposed to know why you get this. But this is what is seen in non-depolarizing. In non-depolarizing block, this is what you will see. And this is what is called as fade. The first response is less. The second response to the second stimulus is even less. The third response to the third stimulus, it's less than that. And fourth is the least, and that is why it is called fade. When you speak of succinylcholine, especially in phase 1, here what you will find is 1, 2, 3, 4. You find the height is reduced, but they are same. So you say this is called as basically decrease amplitude, but same height. Okay, this is called decrease amplitude and same height. Okay, this is succinylcholine phase 1. This does not show fade. But remember, when we study non-depolarizing muscle relaxants, there is a point in when a patient has plasma cholinesterase deficiency, or someone, not exactly, but someone who's having atypical plasma cholinesterase or pseudocholinesterase, and if someone has, if you give very, very high doses of succinylcholine. Remember, succinylcholine is the shortest acting muscle relaxant. Succinylcholine gets destroyed by plasma cholinesterase. There is no role of acetylcholinesterase over here. So succinylcholine gets destroyed by plasma cholinesterase in how much time? In about 5 to 8 minutes, and some books have mentioned 8 to 10 minutes or 8 to 14 minutes, because of which succinylcholine is called as the shortest acting muscle relaxant. Not just the shortest, it is also the fastest acting muscle relaxant. Right? But the point is, it is called shortest acting muscle relaxant because it gets destroyed by the pseudocholinesterase which is present in the plasma. It's also called as plasma cholinesterase or butyryl cholinesterase. Right? Now the point is, अगर किसी के अंदर ये है ही नहीं, there is no plasma cholinesterase deficiency. This might happen in liver disorders. It might happen in pregnancy, less deficiency, right? It may happen in various other conditions like drug interaction. We're not going to those conditions. But if someone has a deficiency, then instead of 8 to 10 minutes, this will become 8 to 10 hours, right? 8 to 10 minutes, because then it does not remain shortest anymore. Then I will say it becomes the longest acting. Instead of shortest acting, it becomes the longest acting. And that is what is called as a phase 2 block or a dual block of succinylcholine. There's a slight difference between them, but dual block. So now what happens is, instead of a normal 8 to 10 minute block, this become 8 to 10 hour block. The only treatment of this condition is positive pressure ventilation, right? A lot of other things have been speculated, but ideally treatment is positive pressure ventilation because patient is paralyzed. इसमें क्या होता है? Succinylcholine in phase 2 resembles non-depolarizing in features. it resembles non-depolarizing. See, routinely does not resemble, but once it becomes phase 2 block, it resembles non-depolarizing. So when you have given train of 4 ratio, when you've given the train of 4 mode, and if succinylcholine goes into phase 2, if succinylcholine goes into phase 2 block, in that case, remember, it shows the same feature as non-depolarizing. So in phase 2, you are going to see the fade, which is seen in non-depolarizing. So succinylcholine in phase 2 will show a fade, which is not seen in phase 1. Clear? Dr. Prajwal, thank you. Dr. Prajwal को समझ में आ गया. Thank you. Okay. This is an important question. Huh? This is also image based, but okay. But hopefully your points are clear over here. Okay. Next question. A capnograph obtained from an intubated patient undergoing controlled ventilation is given below. Which of the following is likely cause of the finding seen? Okay. Esophageal intubation, inspiration with cardiac oscillations, a bronchospasm, or a spontaneous respiratory effort. Okay. Dr. Rohit Paul says 𝐒𝐄𝐈𝐀. Very correct. Dr. Tasmina says D. Dr. MedEd says D. Dr. Prajwal ने से बोला 𝐒𝐄𝐈𝐀, पर ऑप्शन सी क्यों लिखा? 𝐒𝐄𝐈𝐀 करेक्ट है. हाँ डॉक्टर प्रज्वल, सी क्यों लिखा? मैं वही सोच रहा था. डॉक्टर प्रज्वल, why has he mentioned C? Correct. Answer is D. So all of you are well prepared. Correct. Spontaneous respiratory effort. What you see here is 𝐒𝐄𝐈𝐀. Correct. Absolutely correct. Esophageal intubation. So when we are discussing this, capnography. Capnography basically, guys, nothing but is a graph of carbon dioxide. In simple terms, without going into too much details, it's a graph of carbon dioxide. So you have a monitor. Dr. Prajwal says गलती से टाइप हो गया. ठीक है, पर डॉक्टर प्रज्वल ये गलती एग्जाम में भी होता है. Be careful. Okay. Same point, Dr. Prajwal, many times, people come out from the exam and they say, I've marked it correctly. Be careful when you mark in the exam, and especially for students of FMG who are attending, I'll tell you, don't change your answers. The biggest mistake that I have thought that most of the FMG students have done, which I feel, that is my personal opinion, FMG I'm talking about, though it is, the point is most of the students I speak, and the ones who have got 147, 148 and 149, the FMG students, the most of them, they say, sir, we change the option. अरे don't change it. बार-बार change नहीं करना होता exam में. Exactly, Dr. MedEd says. Number जाएगा exam में. बिल्कुल. This is where you mark a question, you think you're right, just mark it. Don't go back and change. This is where you make mistakes, and I've seen that maximum happening with students with 147, 148 and 149 who have scored in FMG. They have most of the time said, sir, we changed the answer at the last moment. हमको लगा ये गलत था, हम जाके change कर दिए, and this is the. If you feel it is correct, just mark it and leave it. That's what I feel. ठीक है, especially for FMG. Dr. Rohit Paul, sir, can you please explain the other graph of capnography? वही लंबा क्वेश्चन चलेगा तुम लोग को. I'll take a long session. मेरे को पॉइंट था कि 2 घंटे लूंगा मैं. Briefly, ठीक है. I'll try to finish off as early as I can because we have almost. I'm covering all anesthesia. पूरा cover कर रहा हूँ मैं almost. मतलब the images. ठीक है. So I'll do the graph also. Don't worry. I'll do the graph also. So right now we have coming to capnography. Remember, capnography is a graph of carbon dioxide. इसका मतलब ये है, this monitor. If I have to show you it, what this monitor does is, I want to take one image over here. So what this monitor does is that you have placed a monitor in front of the endotracheal tube, and the whole function of this monitor is that it detects carbon dioxide. So whenever the carbon dioxide is coming out from here, it's going to detect, right? That means whenever inspiration is happening, it's not going to detect. So whenever carbon dioxide comes out, it detects CO2, so the graph goes up. When inspiration happens, it is not detecting carbon dioxide, the graph goes down. So whenever the graph goes up, it is expiration. Whenever the graph goes down, it is inspiration. This is the basic of, okay, this is the basic of capnography, right? That's the basic of capnography. Right, so basic of capnography, I told you, whenever the graph goes up, it is expiration, right? Graph going up is expiration, graph going down is inspiration, graph going up is expiration, graph going down is inspiration, graph going down is graph going up, this is expiration, this is inspiration. So this part explains to you about expiration. The rest is inspiration. This is inspiration from here to here, sort of, right? This is basically expiration. The next that you see is inspiration. So continuously, when you get a graph like this, it tells you that expiration and inspiration are taking place. Expiration and inspiration are taking place. And this is normally seen in IPPV, which is seen in controlled ventilation, or when you have intubated someone correctly. So this graph is seen in correct intubation, right? Or correct ventilation. That's the graph which you see, which shows you proper expiration and proper inspiration, proper expiration, proper inspiration, proper expiration, proper inspiration. If I keep this in front of me, when we are breathing spontaneously, you get a graph like this. Okay, this is what is seen in spontaneous. Now, I was giving IPPV to someone, और suddenly उसने spontaneously सांस ले ली. Means I was giving IPPV, it's going on properly, and he inspired in between the IPPV. So you get a graph like this. He took a breath in between IPPV, which means IPPV was going on, and in between IPPV, someone took a breath. So this is what is called as spontaneous breathing during IPPV. And after some time, the graph will become spontaneous. And this is the meaning of what you can see, spontaneous respiratory effort during IPPV. This is the actual point. Okay? Okay? This is spontaneously respiratory effort during IPPV, which you have seen. That's why it's called 𝐒𝐿, which means out of the muscle laxant effect. Right? That's the first thing. Now, second point. This was about, now you get a graph like this. What does it mean? You got some carbon dioxide, and after that there is no carbon dioxide coming out. Why is no carbon dioxide coming out? Because your tube might have gone in esophagus. So this would suggest esophageal intubation. So this graph basically you can call as sudden drop in EtCO2. Sudden drop means it is there, it is suddenly it's gone. Another reason for sudden drop is, one is because it's gone into esophagus. So if it's gone into esophagus, you will not get carbon dioxide. A little bit of CO2 in the airway passage will detect, and suddenly there is no CO2 detected. Esophageal. In case of embolism, most important, in embolism there is a sudden drop of EtCO2. Remember, there is decreased EtCO2 and there is decreased SpO2, and especially during a laparoscopic surgery. And this question has been asked so many times in INI-CET as well as in FMGE and NEET PG. If a laparoscopy surgery is going on where you're using carbon dioxide gas that we just discussed, and if it's causing an embolism, you will get decrease in EtCO2 and SpO2. All right. ये हो गया esophageal intubation, embolism. Also, if someone has died, no CO2 production. So if there is a cardiac arrest, you will get no CO2 production. Complete obstruction of endotracheal tube, or there is disconnection from circuit, accidental extubation, that is also there. But these are the basic points: esophageal intubation, embolism, cardiac arrest, disconnection of the circuit, and accidental extubation. Now, that is the reason for that. If you get a graph like this, it means carbon dioxide is coming out, but it's not coming out in the regular shape, right? Ideally, it should have come out like this, proper expiration. But do you realize the expiration is not happening properly? Why? Because there is some obstruction present. What might be the obstruction? This is what is seen in bronchial asthma or bronchospasm. Correct? So other 2 points you got it, guys? So esophageal intubation mein, you are going to get a graph like this. Bronchospasm, you're going to get this graph which is called shark fin appearance, which I just discussed with you. And inspiration with cardiac oscillation means this, you get to see something during inspiration like this. This graph is seen in pediatric patients or patients with a thin chest wall. So if you get something like this, remember, this is inspiration. This is inspiration. So if you get this small thing happening during inspiration, this is what is called as cardiac oscillations. This is seen in pediatric patients or people with thin chest wall. Okay, got it? अब क्या बचा इसमें से एक और ग्राफ इंपॉर्टेंट है that you need to remember. अगर ग्राफ बहुत ज्यादा हो गया, too much of carbon dioxide production, this means increased CO2. One cause may be hypoventilation, but more important, we have to remember that it can be malignant hypothermia, it can be thyrotoxicosis, anything that increases metabolism, sepsis, fever, use of soda bicarb. And remember, in laparoscopy we use carbon dioxide gas. So when you are using carbon dioxide gas, ideally your graph should have been like this. It should have increased. But in laparoscopy, if you get a graph coming down to 0, that is why it is called embolism. Did you understand? Laparoscopy, I am using carbon dioxide gas for insufflation. Hence, I will expect the graph to go up. This is normal. In laparoscopy, if the graph goes up, it is normal. But in case in laparoscopy, if there is a sudden drop which you see, this is what indicates embolism. That is a question. Another point, especially in malignant hypothermia, and especially if a patient is on soda lime. Remember soda lime? In soda lime, what will happen is carbon dioxide absorption takes place, and this, once the soda lime becomes full with carbon dioxide, suddenly you start to get this step ladder pattern. This means not touching the baseline. More than malignant hypothermia, just remember this is basically seen when there is rebreathing on carbon dioxide. Right? Dr. Noob says MH shows step ladder pattern. Right, Dr. Noob, point ये है कि MH में ना rebreathing अगर होगा तब. Remember, more important, rather than MH, you have to look at other options when this graph is asked in the exam. Yes, it is possible in malignant hypothermia. Why? The point is because if it is not touching baseline, it's anything where there is rebreathing carbon dioxide or more CO2 production, where there is this normally seen in closed circuit. Okay, it is seen in closed circuit. So yes, malignant hypothermia may cause it, but more important than malignant hypothermia, remember, it's rebreathing carbon dioxide. That should be the answer. Okay, Mr. Noob, ठीक है? Capnography लंबा खींच गया, but ठीक है, चलो. All of you wanted a discussion, so we did that. One more point in capnography, last year's NEET PG question. Remember, what are these points? Last year in NEET PG, they had asked you what does the CD represent. So remember here, each point is important. Remember, I told you B and this point is expiration, right? That is expiration, which means this is going to be carbon dioxide. And when it goes down, I told you it's inspiration. So therefore, this and this is regarding inspiration, and the graph goes up, it is carbon dioxide. So this point A to B is basically considered baseline, or it is the dead space. The dead space. Right. So B to C is a mixture of both of them because it starts from the dead space when the carbon dioxide starts to come out. So basically the B to C point, this is basically dead space plus alveolar gas. When complete alveolar carbon dioxide is coming out, this is called as alveolar gas or alveolar carbon dioxide coming out. And this point, this is the maximum alveolar carbon dioxide, which is called end tidal carbon dioxide. And if you can see, the normal value is between 35 to 45, right? EtCO2, the value is between 35 to 45. This is the normal value. This is maximum alveolar carbon dioxide. And after that, when the graph goes down, it is inspiration. Clear? So I discussed this point also. This was last year's question. So we've discussed this question as well, right? So remember this is an important question. So this C to D represents alveolar gas, and after that there is inspiration. Clear? Any doubt, ask me guys. Otherwise, let me go forward to the next question. Beta angle at D, correct. Alpha angle इधर होता है, beta angle इधर होता है. इतना नहीं पढ़ना है. They won't ask you. Correct, Dr. Noob. Alpha angle is here, beta angle is here. Okay. Correct. इतना नहीं पढ़ना है. Anesthesia थोड़ा पढ़ना होता है. इतना नहीं पढ़ना होता है. Correct. The drug shown in the image below can be given by all the following routes except. Okay. Question number 9. Epidural, intravenous, intrathecal, intradermal. Dr. Rashmi. So fast answer jaldi do. Don't want to waste your time also. Yeah, I know time is precious for you guys as well. So just want to finish off fast. Anyone? The drug shown in the image is fentanyl, right? It can be given by all the following routes except, so epidural, intravenous, intrathecal, intradermal. कहाँ से नहीं देंगे? Dr. Vivek says question mark nahi. Be confident, Dr. Vivek. Correct. It is intradermal. Remember, there are 3 drugs from anesthesia which can be given from all the routes. Dr. Marshall, no, B नहीं है. Intravenous दे सकते हैं ना? Fentanyl है. This is fentanyl. Fentanyl is an opioid. ठीक है, Dr. Tasmina, Dr. Naveen, correct. So these are simple questions, guys. Remember, there are 3 drugs from anesthesia. So remember, benzodiazepines में midazolam, ठीक है, opioids and ketamine. Ketamine. These 3 drugs can be given from most of the routes. Most of the routes, except, right? 2 of them will come in except intradermal subcute. In fact, it can be given intranasal also. You know, midazolam can be given intranasal. Ketamine also can be given intranasal. All of you know opioids also can be given intranasal. So midazolam, opioids, ketamine are used from most of the routes except for subcute and intradermal, and that is the question asked in the exam. Okay, so remember this point. We have intranasal midazolam, which is used in pediatric patients for control of convulsions, right? We have opioids, which take care of pain. Intranasal, we have opioids as well. And ketamine also works intranasally. Okay, so this is the next question, right? This was the important point I wanted to discuss. Asked in the exam. Question number 10. Which of the following is correct regarding the layers being pierced during the following procedure? Okay. So skin, subcutaneous fascia, okay, supraspinous, interspinous ligament, dura, skin, subcute, ligamentum flavum, supraspinous and interspinous ligament, skin, subcute fascia, supraspinous, interspinous and ligamentum flavum, and then there is skin, subcute, supraspinous, interspinous and intervertebral disc space. Yes, guys. All of you, correct. Dr. Naveen, Dr. Marsh Edits, Dr. Tasmina, Dr. Noob, Dr. Mr. Noob, Dr. Rashmi, Dr. Prajwal, Dr. Rohit, Dr. Ayush. Correct. Very nice, very nice. All of you, everyone present has given the correct answer. C. Absolutely correct, right? So this is because what is happening is, what is the procedure? The same question can be changed. What is the procedure you can see? As you can see, a catheter is being inserted. Remember, this procedure is basically an epidural, right? So what you see here is a epidural going on. We are putting a epidural catheter. So this is the procedure, right? Epidural. So the difference is that in spinal anesthesia, we use basically thin needle, and spinal anesthesia is given single shot. You give it once and that's it. You're perforating the dura and putting the drug inside the CSF. Plus, you will realize I will always give less volume of drug because your drug is going inside the CSF, that is spinal. On the other hand, if you speak about an epidural, you will find that epidural has a thicker needle. It has got these 1 centimeter markings, right? These are thick needles. And what we normally do is we put a catheter inside from the epidural space. So this is your epidural when we put a catheter, and when you're giving it single shot, it is spinal. What are the layers that get pierced? All of you have given the correct answer. I'm just writing in short so that you have an idea. The first layer is the skin. Then you get the subcutaneous tissue. After that, you get a ligament covering of the spinous process, and this ligament is called as supraspinous ligament. You get a ligament in between the spinous process, and this becomes interspinous ligament. Then you get another ligament over here. This is ligamentum flavum. These are 5 common to all of them. As soon as you puncture ligamentum flavum, remember जब F के बाद कौन सा digit आता है, कौन सा letter आता है, E, उससे पहले epidural, right? So ligamentum flavum के बाद the next thing which you get, this is what is called as epidural. Okay, so after the ligamentum flavum, you get the epidural space. It's a negative pressure space in continuation with the thoracic cavity. So all this space which you see is epidural. So if anyone will ask you, epidural can be inserted in which area? It can be given in any area. Last year's INI-CET question, a patient has come with, fracture rib. What is the thing that you're supposed to give to the patient? The answer there was thoracic epidural. Remember, epidural can be inserted anywhere. It can be inserted cervical also. It can be inserted thoracic also. Epidural. Dr. Rohit says, understood the topic conceptually for the first time. Thank you. Thank you, Dr. Rohit. Thank you. Thank you. Thank you so much. Okay. Epidural. So epidural ka remember cervical. It can be given cervical. There is thoracic. There is lumbar. I mean lumbar as in I am telling you where all you can insert, as well as the sacral. All of you remember sacral epidural is what is called as caudal anesthesia. Sacral epidural is what is called as caudal anesthesia, which is used in pediatric patients and for pain management. This is what is used in pediatric patient. Remember, okay? Don't get confused. So what is caudal anesthesia? It's nothing but sacral epidural. Okay. So if after the epidural, guys, so this was epidural. This is in continuation with the thoracic cavity. So therefore, you can insert in the cervical area. I can insert it in the thoracic area. Here is the lumbar, and I can also go to the sacral. I can go down as well. After that, you get the next two layers, guys, and here is the next layer, right? The next layer which you get here is the dura. Attached to the dura, immediately attached to the dura is the arachnoid, right? Here is the arachnoid. And once you puncture the arachnoid, this area which you get, this becomes subarachnoid, right? And subarachnoid is containing CSF. This is where we give spinal anesthesia. So simple point over here, don't make mistakes, that spinal anesthesia is given inside the CSF. So the last layer punctured is not dura, but the last layer punctured is arachnoid. And for epidural, the last layer punctured is ligamentum flavum. Okay, clear? Right. So when you give spinal, why do you say the most common is, space? The most common space for when you're giving spinal anesthesia is basically L3, L4. Why? Because if you can see, can you see this? Spinal cord is coming over here and spinal cord gets over at this point, right? Where does the spinal cord end? This is anatomy question. Spinal cord ends over here, which is lower border of L1, upper border of L2 in adult, and lower border of L3 in a child. This is an anat question. Huh? So spinal cord starts from medulla oblongata, finishes off at L1, L2 in adult, and L3 in child. So next question आता है, dura कहाँ खत्म होता है? Where does the dura end? Again, that's a question. Dura ends at S2 in adult and S4 in child. All these are MCQ questions. Okay, so L1, L2 in adult and L3 in child. This is where the spinal cord ends, and dura ends at S2 in adult and S4 in a child. Okay, so now the point is, when we are discussing most common is L3, L4, L4, L5. हाँ, वो सब डिस्कस कर लिया ना हम लोगों ने, राइट? क्या बोलना था मुझे? हाँ, so that's the reason why the most common space is L3, L4, because if you give spinal anesthesia above L1, L2, guys, you can damage the spinal cord. Correct? If I'm giving spinal anesthesia, I will straight away damage the spinal cord. So that is why when you're giving spinal, the spinal cannot be given in such a way when you're damaging the spinal cord. Correct? That is why in spinal you have to give below L1, L2. But in epidural, because I'm outside the dura, see here is the dura, and this is my epidural space. So if I'm putting it in the epidural space, I can insert it anywhere because I'm not puncturing the dura. But remember, if you puncture the dura with an epidural, you are going to cause a damage to the patient, especially in the cervical or the thoracic area. So if you put a thoracic epidural, the danger of cervical cord, of the spinal cord being cut is very high, and that's why it's a very dangerous procedure in the cervical or the thoracic area. In the lumbar area, sacral area, epidural is safe, but cervical and thoracic epidural are dangerous, because in case you puncture the dura, your needle will go inside and puncture the spinal cord. Okay, right? Here everyone, another important question that comes in the exam. Remember, there is one line. How do you identify which is the space? How do I come to know? This was exam question. You find the highest point of the iliac crest. You draw a line over here. तो हम लोग हाथ ऐसे रखते हैं ना स्पाइनल में. Lot of patients ask us, sir, how's my waist? Are I'm not seeing your waist. I'm not trying to see the waist. What I'm trying to see, MCQ question, I'm trying to see the tough ears line. When you put hand over there at the back, I'm not measuring the waist. I'm not stitching up anything, ना. कोई clothes थोड़ी बना रहे. How's my waist? This is tough ears line. Sorry. Normally, this is tough ears line. What is tough ears line? It's the line joining the highest point of the iliac crest. Remember, and the line joining the iliac crest, it corresponds to the L3, L4 interspace, right? So this corresponds to the L4. So most of the times we say L4 interspace. Interspace means it can be L3, L4, or it can be L4, L5. And that is how you find it. Okay, so this is what is called tough ears line, the line joining the highest point of iliac crest. Okay. अरे सच में तुम लोग हंस रहे हो? सच में ऐसा होता है? You imagine someone, and the patient sitting on the OT table before spinal has no idea who's standing on the back. He does not know पीछे कटप्पा खड़ा है, कौन खड़ा है. and suddenly we start doing like this, like this. Half the time patients are dancing on the OT table. Next time you go to the OT, you see all this happens in the OT, right? Types of needle. Again, important point. Spinal needles are thin. I told you. Epidural. These are thick needles. Why? You need to pass a catheter from within, and they have 1 centimeter marking so that you know how far you are from the skin, right? That's why it is important. Okay, 1 centimeter marking. Now, this is your epidural needle. Remember, the tip is curved. Why the tip is curved? The tip is normally curved because you want the catheter. See, if I have a straight tip, the straight tip epidural will go like this inside. But if the tip is curved, then what will happen? The needle, the catheter that I'm inserting through the needle, it will go like this. And that is why nowadays what we prefer is the curved tip epidural needle. Again, asked in the exam, which is called as 𝐒𝐻 needle. 𝐒𝐻 needle is identified because it has a curved tip. This tip is curved. Okay, this tip that you see is curved. So 1 centimeter marking, a thick needle. Dr. Mahasharit says L3, L4, L4, L5. What to choose if both are given? L3, L4. L3, L4. All right. This is about the epidural needle. Okay. Spinal needle, guys, can be of 2 types. They are normally thin. This was the epidural needle. Spinal needles are thin, but they are of 2 types. One which you see over here, and the next one that you see is this. There's a difference between them. The first one that you see is what is called as dura cutting. Okay. The first one that you see is called as dura cutting. And can you see dura cutting means it cuts the dura like this. It will leave this much big dural hole or dural rent. So dura cutting needle, or this one example is a 𝐒𝐿, Pitkin. These are dura cutting needles, and these needles can cause more damage to the dura, means more post-dural puncture headache. Again, asked in the exam. On the other hand, if you look at the pencil tip needles, you see the pencil tip needles are basically dura separating. They will make a very small hole in the dura, right? Very small hole. They don't leave a dural rent, so they make a very small hole. These are called dura separating needles or dura splitting. These are basically our pencil tip needles. Whitaker, Sprott, and they basically are causing less damage to the dura. Hence, they are the ones which help you prevent the post-dural puncture headache, again asked in the exam. Clear? 𝐒𝐿, Sprott, correct. Both of you are giving correct, all of you are giving correct answers. Okay, next question. Identify the procedure being performed. Cricothyroidotomy, thoracotomy, tracheostomy, invasive central line insertion. Simple question now? Correct. But it has been asked in exam. ये पूछा हुआ question है, right? Correct. All of you are giving correct answers. Absolutely correct. This is tracheostomy. Then what is the difference between tracheostomy and cricothyroidotomy? You need to know that. Correct, correct. All of you have given correct answers, which is tracheostomy. Yes. Intubation तो इसमें option है ही नहीं अपने पास. Thoracotomy is out. Thoracotomy means thorax. Out of the question. You know it's something near the trachea. Invasive central line again is out of the question. The only doubt should have been between cricothyroidotomy and tracheostomy. That is the only point. So answer here is tracheostomy. Remember, tracheostomy is when you are cutting the rings of the trachea. When you cut the rings of the trachea and you put a tube inside, that is called as tracheostomy. Right? Everyone knows that. But then what is cricothyroidotomy? When you insert from here, right? If I'm putting a tube from here, and this is the cricothyroid membrane. So there is the thyroid cartilage. Here is the cricoid cartilage, right? So there is space in between, especially in boys, that is easily palpable, right? Below the Adam's apple, you can just see below the Adam's apple, which is called the cricothyroid membrane. So here is what you see, the cricothyroid membrane. And if you puncture the cricothyroid membrane and you put a small tube from there, that is called cricothyroidotomy. So when you put a tube from here, this is what is called as cricothyroidotomy. And remember, cricothyroidotomy, all of you must have seen in all the movies. Yeah, you must have seen in all the Netflix series. The Good Doctors. You must be seeing in that Good Doctors. Or the South Indian movie Marcel. You must have seen Vijay at the airport running and he tries to cut someone's throat and saves the life. You must have seen that. Cricothyroidotomy. It can be of two types. What Vijay has shown in the movie, that is called needle cricothyroidotomy. Cut it with something and put a straw inside, right? So that is called as needle cricothyroidotomy. The other one is called surgical. What is the difference between needle and surgical? In surgical, I'm going to put a small tracheostomy tube from here or a small endotracheal tube from here, right? In a needle, you can just give a jet ventilation or put IV cannula and give a ventilation from there. So that is what is cricothyroidotomy, and tracheostomy is when I'm cutting the rings of the trachea. That is called tracheostomy. Everyone understood? Remember, every year one question comes from tracheostomy. They will ask you something or the other related to tracheostomy. Something comes from tracheostomy, of course, from ENT point of view. But ऐसा नहीं anesthesia वालों को tracheostomy आता है. All of us are taught tracheostomy. In the ICU, we also do tracheostomy, but we do more commonly percutaneous. We don't know exactly, or we don't do exactly what the ENT people do, like the long term. But in the ICU, percutaneous tracheostomy is done by all the anesthesia guys, right? Everyone from anesthesia knows percutaneous tracheostomy. So they ask you in the exam also, tracheostomy tube. This has been asked in the exam. Okay, so this is also one important question. Tracheostomy tube, another image, right? Next question. Dr. Rohit says, sir, what is Felix maneuver? Wait, मैं सोचता हूँ भागने के लिए तुम लोग मेरे को वापस खींच के लाते हो. I thought it's a short session. I don't mind, if you guys are okay, I don't mind taking a long session also. मुझे कोई दिक्कत नहीं है. But normally होता है ना कि I don't want to waste your time. What is Felix maneuver? Guys, Felix maneuver is nothing but cricoid pressure, right? So when you have a full stomach patient, right? In a full stomach patient, the biggest problem is aspiration. So if I take the same image, no, let me take this image, the next one. In this patient, let me take this image. So normally what happens is a patient who is full stomach, right? So if this is the stomach and here are the stomach contents full. So in this patient, when you try to intubate the patient, I give a muscle laxant. There's a high chance that if I give IPPV from here, positive pressure ventilation, there's going to be regurgitation of the stomach contents and they can get aspirated inside the lungs, right? They can go inside the trachea and aspiration might take place. So in this patient, you cannot do a bag mask ventilation, right? That becomes contraindicated. ये तो क्वेश्चन मैंने पूछा था आगे, उधर डिस्कस करना था, मैं रॉन्ग जगह डिस्कस कर. इट्स ओके, यू आस्क्ड मी द क्वेश्चन, लेट मी डिस्कस, right? So bag mask ventilation contraindicated. Now I can't give IPPV from here, right, in this patient. So I have to give drugs which are very fast acting. I have to do a fast intubation in this patient. That is what is called as rapid sequence induction. Okay, rapid sequence induction. So rapid sequence induction means here I can't give bag mask ventilation to the patient. It is done for a full stomach patient coming for surgery. So what I will do is I will pre-oxygenate the patient. I will just hold a mask on the patient's face for about 3 to 5 minutes. It fills up the lungs with oxygen, so the patient will not desaturate. After that, what I do is immediately I tell one of the assistants to give a pressure on the cricoid, right? Cricoid, guys, is the complete ring in the trachea. So when we speak of the trachea, guys, so if this is the trachea, right? So in the trachea, all the rings are half rings. The only complete ring in the trachea is cricoid. So if this is the trachea of the patient, the only complete ring is the cricoid. And at the back is the esophagus, right? And esophagus is going connecting in the stomach. So now what happens is, when you are, someone is, I can't give bag mask ventilation and I'm contraindicated. Bag mask ventilation is contraindicated over here. So if I give IPPV, why it is contraindicated? If I give IPPV, some oxygen will go here and some oxygen will go here. What oxygen goes here will further inflate the stomach and cause stomach distension and lead to aspiration, more chances. Hence it is contraindicated. In this patient, what we do is, I will first pre-oxygenate the patient. After pre-oxygenation, I will try to protect the airway by starting the Felix maneuver. Felix maneuver is also called as cricoid pressure, and you give a cricoid pressure of 30 Newton. Remember, this is given by an assistant, not by the someone who's doing it. You press upon the cricoid cartilage. What will it do? It presses upon the esophagus with the vertebra like this, and the cricoid being a complete ring, in case there is regurgitation happening, it will stop over here. Correct? And now once it is given by the assistant, so this is stopped, and after this, so this cricoid pressure has compressed the trachea on the esophagus, and this basically shuts off the esophagus. So now esophagus has become shut off. In case if there's any regurgitation, it will stop over here. Of course, then you start giving the induction agent, plus you give the muscle relaxant. Then you do the laryngoscopy, you intubate the patient, you confirm the position. Okay. After all this is done, then you release cricoid pressure. And this is what is called as rapid sequence induction, done for a full stomach patient to prevent aspiration. Clear, everyone? Okay. Understood? Silix maneuver, cricoid pressure. Dr. Rohit. Okay. So that's called cricoid pressure. Remember, it's given by an assistant, not by the person who's doing the intubation. Can I go to the next question? Yes. Okay. The joining position shown in the image is Dr. Marshall, it says got it. ठीक है, good. Question number 12. मैं ना आराम से 9 o'clock तक लूंगा फिर अभी. I was thinking of leaving by 8 o'clock, but no. I think I will take by 8:45, 9, hopefully. The joining position shown in the image is a neck flexion and head extension position for intubation, a rose position for intubation, okay. Ramp position for difficult airway, neck extension and head flexion position. You know, this is what the problem is with this question. Anyone? Answers क्या आ गए? So neck flexion, head extension, rose position, ramped position, or neck extension and head flexion. Correct answer क्या है? First of all, what is the position that is being shown? In the position, what you can see is a pillow kept below the occiput. Okay, so you can see a pillow. This pillow is normally a 8 to 10 centimeter pillow below the occiput. Let's go one by one. All right. There is no pillow or something under the shoulder, because if something was under the shoulder also, a wedge or a sandbag, that would have meant rose position, which is used for tonsillectomy or ENT. In rose position, no doubt this is also kept, but in a rose position, you will have something below the shoulder as well. Over here, you will have something below the shoulder also, right? You will have something below the shoulder. That is why it is rose position. So that is used for ENT, and therefore the rose position is out. Ramped position for difficult airway. Yes, for a difficult airway, there is a ramped position which is normally done. No doubt about it, right? And in ramped position, it's also called as head elevated laryngoscopic position. Okay, it's also done. It is normally done in obese patients with difficult intubation, right? Which is called as ramped position. That's done in obese patients. All right, ramped up position where the patient is almost kind of sitting, right? You do it like that. That is called ramped position. Those two are out. The next thing, what is this? It's a position for intubation that everyone knows. Remember, this position for intubation is called sniffing position. Sniffing position, right? Sniffing position means basically what is happening is, then this is what you get. This is what is called sniffing position. You are getting a flexion of the cervical spine, which means there is neck flexion. You get extension of the atlanto-occipital joint, which means there is head extension. So our position is head extension and neck flexion, which makes it easy to intubate. Okay, so where you find the answer, head extension and neck flexion, the correct answer is A. It's neither B, C nor D. Here it has been written head flexion and neck extension. No, it's not the answer, and that is how the question comes in exam. This is an image-based question. I've just changed the option. I've just changed two options to make it slightly confusing. Otherwise, that is what the answer is. It is head extension, neck flexion. That is the position which you see. So therefore, there is a flexion of cervical spine or neck flexion. So this is what happens in the sniffing position, right? This is exactly what happens. Remember, sniffing position, this what you call, is also called as McGill position. Sniffing or McGill position, you keep 8 to 10 centimeter pillow under the occiput, and here what will happen is you get a neck flexion at the lower cervical spine, and you get a head extension at the atlanto-occipital joint. Remember this point: neck flexion and head extension. what happens in this position is then three axes come in one line: the oral axis, the laryngeal axis, the tracheal axis. Okay, so the tracheal axis, the laryngeal axis, and the oral axis, they all will come in one line. So again, our question comes in the exam: what happens in this position? You get the three axes coming in one line: the laryngeal axis, the pharyngeal axis, and the oral axis. All the axes, they come in one line, and because of which it eases the laryngoscopic view. Means once you put a laryngoscope, but in image it seems like D. कौन सा image में? नहीं तो D कैसे हुआ ना? Same ही तो हुआ. Look at this image ना. It's the same image which you can see over there, right? It's the same image which you see. That is what is called as the intubating position, right? If you're seeing these diagrams over here, I mean the lines, then I don't know. I mean, if you're seeing something like that, but basically this is what is called sniffing position, which you do. It's the same sniffing position which you see over here, right? Yes, so same position. A lot of people also call sniffing or McGill position as a barking dog position, because the dog barks also like this only. ना कुत्ता भौंकता भी तो ऐसे ही है. Dog barks also like this only. Correct. Dog will bark also like this. So if you're getting confused because of the lines which are present, that's a different thing, right? But I've told you the points also. So remember, even if the point is image is not very appropriate according to how you want it, still when you say about intubation, all of you know that point number B and C are out. You are confused between A and D. So remember, whenever you have to do intubation, even if the image is wrong, guys, remember, for intubation the position is always head extension and neck flexion. Forget the image also. If I don't have the image and the question is asked, what position do you use for intubation of a patient? Forget the image. Again, the options remain the same. Here also you will have the same option, and you have to mark the answer as head extension and neck flexion. Am I right, guys? Okay. And barking dog is the same position. A lot of people call it as a barking dog position also. Sniffing or McGill position is also called as a barking dog position. Correct. Because the dog barks also like that. Okay. The point is to be aware कि points उसमें क्या होना चाहिए, right? Head extension और neck flexion होना चाहिए patient में for intubation position. Okay. Had they mentioned instead of intubation that this is a neck extension and head flexion position for maybe tonsillectomy, for maybe tracheostomy, then you can have thought about it. But here the options given are intubation. So forget the image also. When you've asked about intubation, the answer has to be head extension and neck flexion. Clear? Hopefully clear. All right. So therefore, when you do laryngoscopy, again, important base, all of you know this question. I'm not going into too much details, but the first one is what is called as the Macintosh forceps. Sorry, Macintosh laryngoscope blade. This is the curved blade that is used in adults, right? The straight blade is what is called Miller's. This is used in pediatric patient. And the third one that you see is a hinge tip blade, which is called McCoy. Okay, so this is the McCoy laryngoscope blade used for difficult intubation. Okay, this is used for difficult intubation in anesthesia. Dr. Rashmi says, sir, class 10. अभी मेरे पास और क्वेश्चन है, क्या करूं? मैं तो सोचा था 8 o'clock छोड़ दूंगा, लेकिन I don't know. When doubts came, I'm answering everything. Na? Maybe till 9, 8:45, 9. Another hour I'll take. Dr. Rashmi, maybe 1 hour. Okay. We were discussing the points and all the images from anesthesia. Na? So hopefully discussion okay. I did not think I'll discuss capnography so long, but I discussed capnography long. I discussed neuromuscular monitor long. और कौन सा topic long discuss किया हम लोगों ने? Cricoid pressure. I have not thought of that much what we discussed in cricoid also. But my point was you should have your doubts cleared. Whatever doubts are there, I'm trying to solve them to the best of my knowledge. Okay. Dr. Noob says, want to continue the class, completing anesthesia in one go. Okay, done. I'm okay with that, guys. I'm okay. I'm absolutely okay. Any doubts is there, you can ask me. Ask me anything. But hopefully I should be able to answer that anything that you ask me. Okay. Ask me anything. Next question. Okay, so Macintosh blade, Miller's blade, and McCoy blade, they are again important image-based questions asked in the exam. Okay. So we were discussing laryngoscopy. We discussed the position, what happens over there, and the types of blades which are there. Okay. Next. Question number 13. Dr. Rohit says, we are there till you teach, sir. I'm there, guys. Don't worry. Don't worry. Don't worry. Any question? Once I'm done with this also, and if you have any other doubt, I'll solve that as well. Okay. Let me finish off the questions that we have so that the image-based at least part is done. Apart from that, if you have any doubt, we'll ask that. Okay. We'll clear that as well. Thank you, guys. Thank you. Okay. Dr. Prajwal says, nice to learn anesthesia from you. Thank you so much, guys. Thank you. Question number 13. The marked point in red on the adjoining device is A, depth marker, B, centimeter marking from the tip, C, size of endotracheal tube, and vocal cord guide is D. Yes, anyone? Right, I think everything is image is seen clearly, right? So what is that point marked? Depth marker, centimeter marking. Yes guys, anyone? कोई आंसर मेरे को दिखा था तब तक चला गया. एक आंसर दिखा. Anyone guys? देखो थोड़ा सा कंफ्यूज करो. करेक्ट, वेरी नाइस डॉक्टर नूब, वेरी वेरी नाइस, वेरी नाइस गाइज, वेरी नाइस. थोड़ा सा मैंने चेंज किया. दैट्स द करेक्ट आंसर, बिकॉज मैंने क्या किया, इसको हाइड कर दिया था. व्हाट आई डिड वाज आई हिड दिस. इसको मैंने छुपा दिया. करेक्ट, इसको मैंने छुपा दिया था. राइट, व्हेन आई मेड दिस स्लाइड I hid all these things and I just asked you what is this. But that is what you're supposed to know, guys, because when they ask you other devices, you're supposed to know this. So you saw the difference between them. If I had given you this image, you know the answer. Right? All I gave you this. So what does this indicate? Depth marker. अगर ये 10 दिखा रहा है, ये 12 दिखा रहा है. Right? So you thought what? This is 6, this is 4, this is 2, and this is 3. Something like that. इसलिए आया depth marker. Remember, whenever you have put something near the vocal cord guide, what is normally mentioned, the first thing that they mention is the size of the endotracheal tube. Okay, that is the size of the endotracheal tube. So remember, all these markings on the endotracheal tube become important, that they ask in the exam. Depth markers are these 14, 12, 10. This is a pediatric endotracheal tube. Okay, so you will have 8 and almost 6 over here. Okay, something like that. You will have something over here. So you see, these markings are kept. यहाँ पे कोई ब्लैक मार्क ही नहीं है, स्ट्रेट अवे 3 लिखा है. राइट, यस, इट मे बी अ लिटिल बिट कंफ्यूजिंग थिंग, बट जस्ट रिमेंबर दिस इज व्हाट इज टेलिंग यू द इंटरनल डायमीटर. ओके, थोड़ा तो कंफ्यूजिंग करना था ना यार, एग्जाम में तो ऐसे भी ठीक आएगा, इजी आएगा. सो वी कैन हैव समथिंग डिफरेंट ओवर हियर. व्हेन यू आर ऑन दिस साइड ऑफ द टेबल, you have a choice to make it slightly easy or difficult, right? As a student becomes slightly difficult, I understand that point. So let me discuss in detail what we are discussing about. So remember, this point which you see at one end, this is called the connector. Everyone knows this. 15 millimeter connector that gets attached to the endotracheal tube. I mean, this end gets attached to the umbu bag. It gets attached to the anesthesia machine. So, right, that is the machine end. On the other hand, this part which you see here is called the bevel. The end of the endotracheal tube is called the bevel. Let me take it away slightly. Okay, now you can see this. This part is called the bevel. Bevel is basically the patient end. Right, after that, what you see over here is the cuff. So another question can come in the exam. Okay, let me make a question. Please answer this. Cuff. What type of cuff is used nowadays? All right, so I'll give you 4 options: low volume, low pressure, high volume, high pressure, low volume, high pressure, high volume, low pressure. Yes, anyone? 4 options. ये option A, ये option B, ये option C, ये option D. Yes. Cuff is what type? Low volume, low pressure, high volume, high pressure, low volume, high pressure, and high volume, low pressure. So Dr. Rohit and Dr. Shweta, Dr. Naveen, Dr. Prajwal, correct. This is high volume and low pressure cuff. Okay, correct. All of you are right. So the cuff that you see nowadays is a high volume and low pressure cuff, right? So the cuff which we normally use, which is present nowadays on the endotracheal tube, these are high volume and low pressure, because in the past what used to happen, if this was the trachea and here is the endotracheal tube, in the past the cuff was like this. If you will see, this cuff is low volume. Can you see the volume is less, but the point is all the pressure is at one point. So this was called as the low volume but high pressure cuff. The volume is low, no doubt, but all the pressure comes at one point, leading to problems, tracheal stenosis, you know, all that problems of intubation. Nowadays what they have done is they have made the cuff in such a way that the volume is high but the pressure gets distributed along the tracheal walls. So now this you will find the volume is high, but the pressure is low. Why? Because the pressure gets distributed along the tracheal walls, right? So the pressure gets distributed along the tracheal walls, and this is the kind of cuff which is preferred. And that's why you get a cuff like this, which is nowadays, as you can see, the volume, the pressure gets distributed along the tracheal wall. So this is high volume and low pressure cuff. High volume, and this is what prevents aspiration. So in case there is any regurgitation that comes in here, that regurgitated material will come and get blocked. All right. So this is what is called as a high volume, low pressure cuff. Clear, everyone? And this is what prevents necrosis. Correct, correct. Dr. Noob, absolutely correct. This is what prevents that necrosis or tracheal stenosis, the complication that you get. Basically, it's preventing the pressure damage to the trachea, right? That's the kind of cuff we use. So high volume, low pressure cuff. And when you inflate the cuff, remember we use 5 to 10 ml of air or saline. More important is the cuff pressure, which should be less than 25 to 30 centimeter of water. Remember always this is centimeter of water, not millimeter of mercury. Last year INI-CET they had asked a question, pop off wall. No, INI-CET NEET PG. Okay, तो उसमें भी यही था confusion between centimeter of water and millimeter of mercury. So here it is centimeter of water. Cuff pressure should be less than 25 to 30 centimeter of water. That is what prevents the aspiration. All right. In a pediatric, it goes slightly less. This I'm talking of adult. In an adult, it's in a pediatric, it is around 20. It should be less than 20. All right. The cuff pressure should be less than 20 for a pediatric patient. In case you're using a cuff in pediatric patients. In case. All right. This is the pilot balloon from where you will fill in the wall, right? And through the inflation line, the air goes inside and it inflates the wall. Correct. This is how the cuff gets inflated, and this is what helps you to prevent aspiration. That is the whole point about endotracheal tube. You put an endotracheal tube is to prevent aspiration, right? That's the point. The next line that you see over here, guys, this is what is called as a vocal cord marker or vocal cord guide. This is supposed to lie at the vocal cords. That black line which we saw right now, that is supposed to lie over here. That is what is called as a vocal cord marker or vocal cord guide. Beyond that, the next thing which you see is the ID, right? So this was our vocal cord marker. The next is ID written, ID. That ID, this is basically the internal diameter. Internal diameter is nothing but the size of endotracheal tube, right? Also, resistance of endotracheal tube is inversely proportional to the internal diameter. Resistance of the endotracheal tube, it is inversely proportional to the internal diameter. Okay, remember that. And internal diameter tells you the size of endotracheal tube. The next you have single use, oral, nasal, that is written. And these points which you see, this one, you see there's another thing called as outer diameter written. This is outer diameter, not very important. So the one is internal diameter, other is outer diameter. And then you have these markings 10 and 12 and 14. This is what is called as depth marker. These points are what are called as depth marker and centimeter marking. Both are the same. Depth marker and centimeter markings are the same. These points which you see, they are called depth marker. They are basically centimeter mark from the tip. Okay, these are centimeter mark from the tip. So these are what are called as depth marker. How is it important? In a male patient, adult male patient, those depth marker in a male patient has to be 21 to 23 at the teeth. In a female patient, it is 19 to 21, and that is the importance of the depth marker. Or they may be called centimeter marking. The last thing that you will see on endotracheal tube, right? And there's another line which, if I don't know if it's very clearly visible or not. Can you see there's a blue line which you see? That's a radio opaque line that you see on the X-ray. If you will see, there is one line that you will see. A blue line is seen over here. That blue line, what you see over here is what is called as the radio opaque line. This is seen on the X-ray. Okay, this line which you see over here, this is what is called as the radio of this line. There's a blue line which you will see passing all through here. A blue line which passes like this all through the tip. You can see it over here also, right? That is called radio opaque line. And the last thing on endotracheal tube, remember towards the end you have a small opening, right? And that small opening is what is called as Murphy's eye. A small opening which you will see over here towards the end near the bevel, that is what is called as Murphy's eye. Murphy's eye has been given as an additional port for ventilation. It it is given as an additional port for oxygenation and ventilation in case your bevel gets blocked. So this will be an additional port for oxygenation of the patient. So that is called Murphy's eye. Thumbs up, guys. Everyone okay? So that was about endotracheal tube. We saw all the markings over there. And this is called the pilot balloon, from where you fill in the air. And it goes from the inflation line. Okay, clear everyone? The air passes through. So we've discussed this as well. Here we have the image. Next, the adjoining device is which generation LMA? Okay, first generation, second generation, third generation, fourth generation. The adjoining device is which generation LMA? First, second, third, or fourth? Similar questions have been asked, but they have not asked from this device. Aage piche they've asked you. Dr. Meenakshi says okay, Dr. Naveen says okay. Dr. Mash Edits ने एक आंसर दिया, डॉक्टर मोनिका ने एक आंसर दिया, डॉक्टर गौरव ने एक आंसर दिया. कंफ्यूजन गाइस, कंफ्यूजन. हु इज राइट? अरे फोर्थ कैसे आएगा? डॉक्टर जेएमटी, फोर्थ तो नहीं आएगा ना. फोर्थ आउट ऑफ क्वेश्चन है. यू गेट कंफ्यूज बिटवीन फर्स्ट, सेकंड, थर्ड. आई कैन अंडरस्टैंड. ओके, सो आधा आधा है. हाफ द पीपल हैव गिवन आंसर ए, हाफ द पीपल हैव गिवन आंसर बी. डॉक्टर मीनाक्षी 4 नहीं आएगा. Dr. Mr. Noob says LMA Supreme. No, it's not LMA Supreme. Right, most of the people now that it has tilted, now the balance has tilted to option number B. Correct. This is second generation LMA. So you will ask me what is first and second generation LMA. Right, this is an iGel. The device that you see in front of you is iGel. And whenever we speak of LMAs, remember first generation LMA will always have one tube. Second generation LMA will have 2 tubes. Remember nowadays third generation LMA has started. I think it's not available in India, but I think people classify it as Baska tube. A lot of people do call it third generation. You people are not supposed to know that even for INI-CET. But remember third generation भी available है. Third generation भी available है, लेकिन fourth generation as of now नहीं है. Right? What's the difference is what we will see. Right? So remember, first generation always has 1 tube, second generation has 2 tubes. So all of you will ask me, sir, इसमें 2 tube कहाँ है? So first tube is here, which is called as the airway tube or the intubating tube. Not intubating tube, but the airway tube from where you ventilate the patient. This is called the airway tube or the ventilating tube. Right, we call it the ventilating tube or the airway tube. Second tube guys यहाँ है. Tube तो नहीं है, but उसका रास्ता बनाया हुआ है. Right, this is the second tube which you can see, which goes like this. This is called iGel. Okay, I'll discuss this again. I'll come back to this point. Let me take another question. Which of the following is correct about the adjoining device? It has the drain tube. It prevents risk and complications associated with intubation. Useful in emergency situation and helps to prevent aspiration. Let me see which of the following is incorrect. ठीक है, बताओ. So I get options C, A, D, C. C, A, D, C. फिर से confusion. यार ये simple question था. This is simple question. So we have to study. We have to read this also. We'll study this also in detail. मैं सोचा इसको ही भाग जाऊँ, but no, we will discuss it out. When you get confusions, we'll have to discuss. B, D. अरे सब आंसर आ गया इसमें. A, B, C, D. सबसे पहले डिवाइस क्या है? What is the device? The device that you see in front of you. Right now I told you first and second generation. ठीक है, 1 tube and 2 tubes. So here you can see 1 tube, you can see 2 tubes. Remember? So now this becomes a second generation device. Right? Second generation device जो होता है, second generation is 2 tubes. The whole advantage is that you can put a rise tube from here. Okay, I know why all of you have got confused. I'm just leaving other confusion. I'm telling you why you have not supposed to get confused over. So therefore, does it have a drain tube? Yes. Correct. It has a drain tube. That is correct point. Does it prevent the risk of complications associated with intubation? Yes. That's also correct. Am I right? So point number one, yes. Point number B, yes. It looks like intubation, right? It is almost like intubation, right? So it is helpful. It prevents the complications associated with intubation, because in intubation, your tube will go in the trachea. There are going to be a lot of complications. You will use laryngoscope and all. Here you just insert it inside. So therefore, it is preventing the complications of intubation. Correct. Useful in emergency situations? Absolutely correct. Absolutely correct. It is useful in emergency situation. It is useful in emergency situation because if you are unable to intubate, at least you can put a laryngeal mask airway and you can help save someone's life, right? You can save someone's life. So in the emergency, it is life-saving device. Absolutely correct. But what is the fourth point where people got confused? हाँ डॉक्टर करेक्ट 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 आप सबको समझ में आया. It helps to prevent aspiration? No, it decreases the chances of aspiration. This is the most important point. It is incorrect. Does it help to prevent aspiration? No. यार एग्जाम में ऐसे ही क्वेश्चन पूछते हैं घुमा घुमा के. एग्जाम में ऐसे ही क्वेश्चन पूछते हैं घुमा घुमा के. The point is you're supposed to be understanding what they have asked you in the exam. The wordings. It's not that you people have not studied, and that's why we tell everyone please solve MCQs as much as you can. Like I'll tell you all. I'm because recently I finished off all the FMG classes. So all the FMGs like NEET PG and INI-CET I finished off long time back. But FMG classes, guys, for FMGs, every student, we just told them, the ones who could not manage the last time around, we just told them please solve MCQs and MCQs and MCQs. It's not about how much you have read. It's about how much you're going to apply what you have read to the MCQs, and you will come to know only if you solve MCQs. It's not about reading now. It's about MCQs now. Okay? Solve as much as you can because these small things are the problem. So does it help to prevent aspiration? No, it does not prevent aspiration. It helps to decrease the chances of aspiration. Remember, if any device prevents aspiration, the first important thing is that the device has to go inside the trachea and have a cuff. Only that device prevents an aspiration. If a device is outside the trachea, it never ever prevents aspiration. That is the basic concept. Okay guys, thumbs up. Did you understand this point? Any device that prevents aspiration has to go inside the trachea and have a cuff. Only that device can prevent aspiration. So whether it is endotracheal tube, whether it is tracheostomy, even it has a cuff, it prevents aspiration. Anything outside the trachea does not prevent aspiration. Thumbs up guys, is it clear? Why? You will say, sir, it looks like that. Correct. Now it also has a cuff. Correct. But do you realize laryngeal mask airway जो होता है, laryngeal mask airway lies here at the larynx. It lies at the larynx. Can you see the tip lies at the esophagus? The tip of the laryngeal mask airway, it lies at the esophagus, right? But the most important point is that it lies outside the trachea. The most important point is that it lies outside the trachea, because of which it is called as a supraglottic device. Supraglottic means outside the trachea. The device is outside the trachea, hence it is called supraglottic. So it is supraglottic, lying in the larynx, and the tip of the LMA lies at the esophagus. So you will say, sir, how does it prevent an aspiration? No, it does not prevent aspiration. It helps you to decrease the chances of aspiration. Routinely what happens is, okay, so now what is the difference between first generation and second generation LMA? So this what you see is basically the first generation LMA. This here what you see are the second generation LMA. The point is first generation LMA has one tube, second generation has two tubes. What is the difference between them? In the first generation LMA, remember, you can't give IPPV. It is contraindicated for IPPV. Why? If it's a first generation LMA, this is the first generation LMA. In case it is the first generation LMA, if I will give IPPV positive pressure from here, then what will happen? Remember, stomach is over here. So if I will give IPPV, so the oxygen from here will go inside. Oxygen from here will go here inside the trachea. But the same oxygen from here is also going to go inside the stomach. This will further lead to stomach distension and high chances of aspiration. You will say, sir, cuff to hai. No, but the cuff is not inside the trachea. The cuff is outside the trachea. It is at the esophagus. So if there is a regurgitation, guys, the regurgitation can escape beyond the cuff and it will come inside the trachea. And that is exactly, if you want to prevent aspiration, the cuff has to be inside the trachea and then aspirated. Only then it prevents aspiration, like this. When you speak of an endotracheal tube, in case there is regurgitation, this presence of the cuff inside the trachea is what helps prevent the aspiration. If you have a cuff in the larynx, it does not prevent aspiration. So laryngeal mask airway does not prevent. Dr. Rashmi says, "Aaj samajh mein aaya." Okay, thank you. Okay, so this is your first generation LMA. All right, so all of you have understood the point that if there is regurgitation happening, it will go inside the trachea and it can take place. So therefore, it is contraindicated for IPPV, as the biggest problem is that aspiration. Because the biggest problem here is high risk for disadvantage is the aspiration. High chances of aspiration. So someone said, let's do one thing. Let's put a Ryd's tube, right? Or Ryd's tube from the nose, from where we can suction the stomach. Well, let's put a Ryd's tube from the nose and we can suction the stomach. ये कर सकते हैं. लेकिन फिर किसी ने बोला, let's combine the two of them together. Instead of using a separate Ryd's tube and a separate oral tube, let's combine both of them together. और वहां से बना second generation LMA. Now the second generation LMA has given you a drain tube which can pass out inside the stomach, right? Second side drain tube which can go inside the stomach. So the same thing which we discussed, I-gel, this is going inside the stomach. Correct. So if it goes inside the stomach, you can consider and you can do aspiration of stomach contents. So second generation device has a drain tube, and from the drain tube I can insert a orogastric tube, a Ryd's tube that goes inside the stomach, and I can do a suctioning from there. Because I can do a suctioning, remember, second generation LMA can be used for IPPV. I can. But does it prevent aspiration? No, it does not prevent aspiration. Though I can use it for IPPV, still it does not prevent aspiration. Yes, it decreases the chances of aspiration. It decreases the chances of aspiration because I can put a Ryd's tube from there. My second generation will have a second tube and the Ryd's tube will go inside the stomach. No doubt I can do a suctioning. No doubt. But imagine, अगर मैंने suction नहीं किया and patient vomited. And the patient vomited. I put a Ryd's tube inside the stomach. It has gone inside, and I did a suction, so I could use it for IPPV. So that's the difference between second generation. I can use it for IPPV, right? But in case the patient vomits, I didn't suction, and all the regurgitation will come from here and go inside. Therefore, to prevent aspiration, your tube has to be inside the trachea. Okay. Dr. Gaurav says, tip at trachea, NG tube will pass to stomach. हाँ, correct. NG tube का वही बता रहा हूँ. NG tube जो हुआ, NG tube नहीं, तुम उसको Ryd's tube बोलोगे. You'll call it the Ryd's tube. The Ryd's tube that you insert, the Ryd's tube will pass inside the stomach. So this goes inside the stomach, right? And you can do a suction from the stomach, no doubt about it. But in spite, you can't put a stomach all the time. ना? Suction थोड़ी करते रहोगे पूरे time वहाँ पे pressure लगाए रहोगे. You'll have to take it off. And in between there is regurgitation happening. In between, and you don't have done a suction, then your regurgitation will escape from the side of the esophagus, from the cup from here. And now if you don't have a tube over here, imagine it's like this. So what will happen? Open area. Correct. यहाँ पे open area है, सीधा aspiration हो जाएगा. So it does not prevent aspiration. It just decreases the chances of aspiration. That's the point. Thumbs up, guys. Is it clear? That's about the second generation and first generation LMA. Any device that has one tube is first generation LMA, which has two tubes is second generation LMA. So remember, what are the first generation LMA? The classic LMA, the intubating LMA. You get flexible LMA, which has that wire inside, wire spiral metal wire, and a single use unique LMA. Remember, most of AMBU LMAs are first generation. Second generation LMA, ProSeal LMA, two tubes. You have Supreme LMA, I-gel. Remember, the biggest advantage of I-gel is a cuffless LMA. It has no cuff. Till now, all the ones which you will see, all of them have a cuff. You know, this one, classic LMA, ProSeal LMA, they have a cuff. I-gel has no cuff. It's the most common used in emergency. Okay, so this is your second generation LMA. I think we have discussed both of them. Also, there's one second generation AMBU LMA which is called AMBU Aura Gain. Apart from that, all AMBU LMAs are first generation LMAs. Clear? Hopefully this point is done. Again, I did not think of discussing this in so much in detail, but yes, all of you were getting confused, hence I discussed it out. Okay, so ये हो गया. Next question. Hopefully you've understood all of you, right? Dr. Marsh को भी आंसर दे दिया, सबको हो गया, correct. Next, identify uncuffed endotracheal. ओए एक पॉइंट था, uncuffed endotracheal ट्यूब लिखना था, चेंज हो गया, सॉरी. Uncuffed endotracheal tube, oropharyngeal airway, nasopharyngeal airway, microlaryngeal tube. Yes. Uncuffed endotracheal tube, oropharyngeal airway, nasopharyngeal airway, or a microlaryngeal tube. अरे B कहाँ से आया? All of you are giving B. No, this was last year's NEET PG question. Oropharyngeal नहीं है, nasopharyngeal है ये. Giddle नहीं है. Giddle airway is this, guys. Giddle airway ये होता है. This is what is called giddle. अरे don't get confused. Simple question था ये. This is a nasopharyngeal airway. This is last year's NEET PG question. ये सेम वही क्वेश्चन है, मैंने बस ऑप्शन चेंज किया है. फर्स्ट ऑप्शन, ये सेकंड, लास्ट ऑप्शन चेंज किया है. वहां पे they had asked you 𝐻𝐻 airway, and I put a microlaryngeal tube. Only one option. In fact, this option is also from the same place. Same thing. Same question asked in the NEET PG last year. Same. First of all, why is it not an endotracheal tube? You know. Why is it not an endotracheal tube? You don't have those markings. Though number 7 has written, but still, do you see any Murphy's eye? No. Do you see a vocal cord guide? No. Can you see internal diameter written over here? No. But yes, possibly this can be written here also. But do you have those depth markers? No. Do you have that blue line, radiopaque line? No. That is why it is not an endotracheal tube. Remember, cuff नहीं, uncuffed tube है ना, बच्चों में normally use होता है. Remember, uncuffed endotracheal tube is used in pediatric patients. So you have uncuffed tubes like the one which we saw here. The one which you saw here has a small cuff. This endotracheal tube has a cuff, which we were discussing. This has a cuff, but normally small endotracheal tubes do not have a cuff, which are used in pediatric patients. Okay, small endotracheal tubes normally do not have a cuff. Okay, so when you speak of endotracheal tube, uncuffed endotracheal tubes is used in pediatric patient less than 6 to 8 years of age. Why? Because the shape of the airway is cone, like this. The subglottic area is the narrowest. This is the glottis of the patient, right? You have a cone-shaped airway, conical or a funnel-shaped airway for a pediatric patient, right? And this area, subglottic area, is the narrowest. And that is why you use uncuffed endotracheal tube in a pediatric patient, 6 to 8 years of age, less than 6 to 8 years of age, right? So first thing is, this is not an endotracheal tube. I've told you the reason. So microlaryngeal tube is also out. Microlaryngeal tube is basically a specialized tube used in an ENT vocal cord surgery, right? But it's also an endotracheal tube only. So again, microlaryngeal is out and uncuffed endotracheal tube is out, right? It does not have the markings of endotracheal tube. Remember, all the markings of endotracheal tube are absent. Your confusion is between oropharyngeal and nasopharyngeal. So this tube which you see over here, this is what is called as oropharyngeal airway. This is what is called as Giddle's airway. This is what is called as a nasopharyngeal airway. Remember, it resembles an endotracheal tube, but it is not an endotracheal tube. Okay. What they do, both of them do the same thing. Oropharyngeal airway also, it prevents the backfall of tongue on the posterior pharyngeal wall. It prevents the backfall of tongue. Oropharyngeal airway. And remember, the size of oropharyngeal airway is between the corner of mouth to the angle of mandible, right? Between the corner of the mouth to the angle of mandible. That is the size, adequate size, and it prevents the backfall of tongue. Remember the contraindication, never use it in awake patient, because in awake patient, if you use a oropharyngeal airway in awake patient, it will stimulate the gag reflex. And if it's, see where it's going, it is going to stimulate the gag reflex, right? If you put it over here, it's going to stimulate the gag reflex. And if there is a gag reflex happening in the patient, it can lead to laryngospasm, vomiting, and aspiration. and that is why you have a nasopharyngeal airway which you can pass from the nose. The size is between the tip of the nose to the tragus, right? From the tip of the nose to the tragus of the ear. It does the same thing. It prevents the backfall of tongue, but remember, it bypasses the gag reflex. So nasopharyngeal airway, it prevents the same thing. It prevents the backfall of tongue. Sir, AMBU LMA is first or second generation. Most of the AMBU LMAs are first generation. Most of them, except for AMBU or again. According to me, it keeps on changing. When they get a new device, it will change. So Dr. Naveen, hopefully that answer is right. And Dr. Gaurav ने answer दे भी दिया. Very good. Prevents backfall of tongue. Nasopharyngeal airway. ठीक है. इसका सबसे बड़ा एडवांटेज ये होता है that it bypasses the gag reflex. क्योंकि पीछे से जा रहा है. So nasopharyngeal airway is basically going from here. It's going from the nose, na? So it bypasses the gag reflex. So nasopharyngeal airway goes from here. This is the nasopharyngeal airway. It also prevents the backfall of tongue, but it is going from the nose. Correct. So therefore, it bypasses the gag reflex. So therefore, it can be used in awake patient. ठीक है? Clear? Next. This procedure, कहाँ गया procedure? Image ही नहीं आया, रुक जाओ. Wait, that image should have been there. Just give me a second. ये image चला गया, तो give me 1 second. Okay, now this procedure is contraindicated in all of the following conditions except all right. Don't worry guys, I'll take about half an hour, 40 minutes, half an hour more, half an hour, 40 minutes, I'll be done. Okay. C. Tracheoesophageal fistula. D. Congenital diaphragmatic hernia. A. Pregnant patient. Yes, Dr. Gaurav, correct. Correct. हो क्या रहा है? What is happening is, okay, you got confused with the image. What is happening is basically there is a mask kept over here. There is a bag kept over here. What you can see in the image is nothing but bag mask ventilation. Okay, bag mask ventilation. No, the correct answer here is B. Cardiac arrest. Except पूछा है. Correct, Dr. Gaurav. Correct. What you can see is a bag mask ventilation. Bag mask ventilation का ही type होता है AMBU ventilation. It's the same thing. Bag mask ventilation is what we do in the OT under anesthesia. AMBU is what you people have seen in emergency and casualty. It's the same thing. It's called bag mask ventilation. Good, Dr. Gaurav. Pregnant patient में contraindicated होता है ना, risk of aspiration. A is not there. I'm coming to that point. So this is what you're supposed to know. Na? What are the risk of aspiration conditions? ये तो question था. Where do you do Selix maneuver? Guys, this is the answer to that. All these conditions, वो Selix maneuver कहाँ पढ़े थे हम लोग? याद है? This is where I wanted to discuss cricoid pressure with you. So therefore, this is what is called as bag mask ventilation. So remember, bag mask ventilation का contraindication क्या होता है? Bag mask ventilation का contraindication होता है all the conditions with risk of aspiration coming for surgery. So therefore, what are the conditions that are called as risk of aspiration for surgery? So therefore, the first thing which is called risk of aspiration is a full stomach patient coming for surgery. Full stomach patient. Full stomach मतलब जो खाना खाया है, this patient coming for surgery. So these are your risk of aspiration conditions. Full stomach patient. Pregnant patient is pregnancy is always considered a risk of aspiration. Not just food in the stomach, anything in the stomach is full stomach. Whether it is obesity, it is tumors, it is ascites, right? So full stomach pregnancy are risk of aspiration. Apart from that, anyone having intestinal obstruction or volvulus, hiatus hernia, right? Apart from that, congenital causes like congenital diaphragmatic hernia, tracheoesophageal fistula, meconium aspiration syndrome, and pyloric stenosis. इसमें से congenital diaphragmatic hernia, pregnancy, full stomach, ये बहुत बार एग्जाम्स में पूछा गया है. These are all risk of aspiration conditions where bag mask ventilation is contraindicated, right? In this case, you will not do bag mask condition. It's contraindicated. All these conditions they've asked in the exam. This is exactly where you do, if you have to intubate this patient coming for surgery, this is exactly where I do the Selix maneuver, which I just discussed with you. क्योंकि ये patient full stomach है and I have to intubate this patient, correct? So in this patient, I am going to use that cricoid pressure. Remember, 30 Newton cricoid pressure is given on the cricoid cartilage, which is called Selix maneuver. And then I will intubate the patient so that this patient does not aspirate. So this is the point. So risk of aspiration conditions are full stomach patient, pregnancy, intestinal obstruction, volvulus, hiatus hernia, congenital diaphragmatic hernia, tracheoesophageal fistula, right? All these conditions where you will not do a bag mask ventilation. So pregnant patient is a contraindication, tracheoesophageal fistula is a contraindication, congenital diaphragmatic hernia IDA is a contraindication. कोई मर रहा होगा, someone is dying, you can't not do bag mask. Of course, the first thing you will say ki yes, if you get endotracheal tube, you will intubate the patient. I'm not denying. But presently, if there's cardiac arrest, you are supposed to be doing bag mask or ambu. You'll just try to save the life. Forget what is the patient is there for. Okay? Is it clear, everyone? Clear? Dr. Rohit says okay. Right? The point was to discuss about contraindications for bag mask ventilation. So all these conditions that I discussed with you are conditions of bag mask ventilation contraindication. Next question. Hopefully people have understood. Right. A patient had injury leading to massive blood loss resulting in hypotension. A patient requires rapid fluid infusion. The following IV cannula is used? What is the gauge? Dr. Gaurav says RSI. Correct, Dr. Gaurav. Hopefully people have understood. Thank you guys. Thank you. Sure. Next question. इजी है ना, ये इजी है, एग्जाम में पूछा हुआ था, सिंपल. सॉरी बहुत देर तक डिफिकल्ट क्वेश्चंस लग रहे थे तुम लोगों को. ठीक है, दिस इज इजी, राइट? इट्स नॉट अ क्वेश्चन ऑफ इजी यार, इट्स अ क्वेश्चन ऑफ यू हैव टू अंडरस्टैंड द कांसेप्ट बिहाइंड. ओके, डॉक्टर रोहित सेज 90. हाँ करेक्ट, 90 है, 90. Okay, all of you are correct. Absolutely, 18 gauge. You are supposed to know the gauge and you're supposed to know the flow rate also. So remember, as Dr. Rohit has said 90, Dr. Noob says 100, Dr. Rashmi says 93. Yeah, dekho, that's what you need to find out. Anything you have to remember like this, anything near 50. Okay, so all of you know, I think, know the colors. So the pink one is the most common used in adults, right? The blue one can be used in adult, it can be used in children. Right, these are all thin gauge. The yellow one is what is used in pediatric patients, it is used in infants, it is used in neonates. एक 26 gauge भी होता है. There's another which is 26 gauge, which is purple in color. Purple. Right, 26 gauge is also there, which is purple in color. Alright, so these are your thin gauge. और जितना thin होता है, the number increases. So 22, 24 and 26 are thin gauge. On the other hand, 18, 16 and 14, these are thick gauge, right? These are thick gauge. Now, thick gauge is basically used for fluid and blood resuscitation in emergency. एक और होता है, which I think people abroad have seen, India में लोगों ने नहीं देखा. एक है 17 gauge, white in color. All the students have been abroad ना, उन लोग को पता होता है. There's one 17 gauge, white in color. This is not available in India. अच्छा, क्वेश्चन आ चुका है? नहीं, क्वेश्चन नहीं आया है, इंडिया में अवेलेबल नहीं है. डॉक्टर गोपिका, दैट्स व्हाट आई एम सेइंग. अच्छा, विदाउट सीइंग योर आंसर, विदाउट सीइंग योर क्वेश्चन, आई वाज राइटिंग इट ओवर हियर. सो आई एम सेइंग there's another one called 17 which is white in color. Normally even I have never seen it. कोई यहाँ वहाँ इमेज में ही देखा. Even I have never seen a white one if it has come. Okay, so therefore these thick ones, 18, 17, 16, 14, they are used for blood and fluid resuscitation. Now the point is regarding the flow rate, कितना fast जाता है. It is different for every book. You are right, some book it has given 94, some book it has given 100, some book it has given 90. So remember, just take values in between. Now, anything close to 90 is around, anything close to 180 is a 16 gauge. Anything close to 50, anything close to 30, anything close to 20. That's how you can remember. Remember the value closest to that. You can't remember that, this is 93 and this is 270. So just find the closest number. You can remember here close to 250, close to 180, close to 90, right? Close to 50, close to 30, and close to 20. That's how you can remember the flow rates. Okay, that is the easiest way. Otherwise, you can't remember the flow rates for all of them, and you can't. Just try to find out the easiest numbers. And I think all of you know the gauge, right? So I don't have to discuss that. Purple one, remember, purple is what is used in neonates and preterm, especially in preterm neonates. The 26 gauge, basically, remember, 26 gauge purple is used for preterm neonates. Preterm, all right? That's done. Next question. A specific complications seen with the following procedure. Question number 19. A specific complication seen with the following procedure. Okay, so chylothorax, empyema, aspiration pneumonia, and Horner syndrome. Horner syndrome. नाम भी कैसा है उसका? Horner syndrome. B. पहले प्रोसीजर क्या चल रहा है? First see the procedure, guys, and then think about it. First see the procedure, guys. Procedure क्या है? If you will see, it is written puncture site between medial 2/3 and lateral 1/3. ठीक है, वो puncture site लिखा है. You can see a needle. Where is the needle going? The needle has going inside this. What is this? This is your blue colored thing. What is a blue colored thing? This is a vein. Which vein is this? You can see subclavian. So therefore, what is the procedure that is going on? This was a question asked November 2023 INI-CET. Okay, July 2023 INI-CET question, but that does not mean it cannot be asked for FMG or NEET PG. It's the same thing. This is basically a central line insertion. You are going inside the vein. I think all of you are getting confused because you're thinking it is a block. Most of you must be thinking it's a block. Maybe it's a, it's a kind of a block that we are giving. Maybe a brachial plexus block where you can get these side effects, right? Brachial plexus block, you must be thinking, or stellate ganglion block near the neck, right? So what you see over here is a central line insertion. First of all, you need to identify the procedure, image-based question, right? So this is a central line insertion. A central line means a central venous catheter. It lies in the central vein of the body. It's a central venous catheter we are talking about, right? It lies in any major vein of the body. It has to be a major vein where we put it. It's not put in a small vein. It's not an IV cannula. It's a central line. Now, when you speak of a central line, guys, remember, wherever you insert the central line from, whether I insert it from the internal jugular, which is the one of the most common sites. Another one common is subclavian, which is inserted from here, right? So subclavian is this one. Then you have femoral, one over here. Okay, these are the three sites, and the another two sites are this peripherally inserted central venous catheter. One is a basilic, another is cephalic vein. So these are the five sites: internal jugular vein, you have the subclavian vein, there is the femoral vein, there is the basilic vein, and the cephalic vein. This is normally used for cancer patients, basilic and cephalic. Correct. Wherever you insert it from, do you realize the tip of the central line lies over here? And this is basically the junction of superior vena cava and right atrium. So wherever you have injected it from, remember the tip of the central line, it lies at the junction of superior vena cava and the right atrium. So what you can see here is a central line insertion, but point is you're seeing it on the left hand side. It's not on the right hand side, right? So we know it's a central line. Empyema. Can this cause an empyema? No. Aspiration pneumonia. It can cause infections, but it is not going to cause aspiration pneumonia. Yes, pneumonia and all will it can cause, I'm not denying, but this will be late. Horner syndrome, it is far away. Horner syndrome will happen in case you inject something over here, and this is where you will get Horner syndrome, not over here. So therefore, those three things are out. But what you can cause over here is chylothorax, because the thoracic duct is running on the left hand side. Dr. Mahasharit says last में आते आते थक गए, ब्रेक चाहिए कि कंटिन्यू कर लें? आई कैन टेक अ ब्रेक ऑल्सो यार, बट माई पॉइंट वॉज कि मैं सोचा नहीं था इतना लंबा चलेगा, मैं तो पूरा ऑलमोस्ट क्लास ले लिया, रिविजन हो गया. I had thought of 2 hours only. They had kept the timing. I mean, we had thought the timing only 2.5 hours. I know you must be tired. If you want a break, we can take a break, but I'll take half an hour more. Another 4 questions are there. 4-5 questions are only there. Almost done. I will finish off till 9. I told you 9 o'clock. I'll finish off before 9. Is that okay, all of you? I'll finish off before 9. Okay. So now here I'm discussing is the subclavian. यहाँ पे thoracic duct run करता है. There is a thoracic duct which runs. Dr. Tasmina says 5-minute break. 5-minute break. अच्छा ठीक है. Okay, let's take a 5-minute break. मेरे घर में it's okay. So I understand you must be tired. 2 hours हो चुका है. It's fine. All of you want a break? Yes or no? Tell me. I'll. Dr. Rashmi says you are amazing. Thank you. Okay. Dr. Naveen says continue. अरे जल्दी बोलो continue या बंद. मेरे को I will take. Let me finish off. हमारे पास जो question है. Let's continue. Let's continue. Let's continue. Let's continue. So everyone says continue. Continue कर लेते यार, आधे घंटे में खत्म कर देंगे ना. We'll finish off. ठीक है. Continue. Everyone has said continue. चलो. Continue. Let's continue. The majority, right? The majority says continue. हाँ, last 4-5 ही बचे हैं. I'll finish off. I think 25 questions है total. Total 25. ठीक है, 25 है questions. 30-35 question नहीं है. It's 25 questions total. Okay. Everyone says continue. ठीक है. ठीक है. I think everyone is continuous. चलो. So as I was discussing over here, what happens is there is the thoracic duct running, and there is always a chance of you puncturing and cutting the thoracic duct, which can lead to chylothorax. So specific complications specific to the left-sided central line insertion, especially if you're inserting on the left side subclavian or internal jugular. Left-sided subclavian has a specific complication which is chylothorax. It will not happen on the right hand side. If you put the central line, which is more common on the right hand side, this is where they catch you in the exam, right? This is where they ask questions. Normally we always insert a right-sided internal jugular vein. We insert a right-sided subclavian vein. But because you have a thoracic duct running on the left side, people normally don't insert on the left side. All of you must have seen normally the internal jugular is on the right side, subclavian on the right side, and we put all the central lines normally on the right side. Left side, you must have rarely seen. All of you have worked in the ICU. It's rare. The complications may be more, and one of those complications can be chylothorax. So therefore, what are the complications that you can get from a central line? So as you see, next to the central, line is in the vein, next is the artery. So straight away what you can get is an arterial rupture. You can get an arterial puncture, arterial rupture, which can lead to hematoma formation. Remember, it's a major vein, so side will be a major artery. So it will be a subclavian artery, it will be a carotid somewhere. Okay, so therefore arterial puncture leading to a hematoma formation. Plus your tip is going to the central, to the heart. It can cause arrhythmias. In fact, arrhythmias is one of the signs to confirm that you have placed your central line correctly. Apart from arrhythmias, it can also cause a cardiac rupture. These are your heart complications that can happen to the blood vessel and the heart. While in puncturing the site, you are close to the apex of the lung. Straight away, you can cause pneumothorax. So pneumothorax, hemothorax, and chylothorax, especially on the left side. Pneumothorax and hemothorax can happen on both the sides, but on the left side, you can get chylothorax. Right? Apart from that, no doubt there can be bleeding, infections, which can be there. Okay, so these are all the complications that can take place. So as you can see from the complications that you see, chylothorax is one of the complications, but empyema, aspiration pneumonia, and Horner syndrome are not there. Okay, clear? So ये question भी हो गया. Central line again is an important question, and this was asked in the exam. This was again asked in the exam. PYT है ये. All right. This identify. No, let me only say it. I've not given any option. As you can see, this is what is called as an intraosseous cannula. You're tired also. Let me question वैसे पूछेंगे यहाँ पे मैं बता देता हूँ. This is what is called intraosseous cannula. You must have read intraosseous in all CPR. If you don't get an IV line, intraosseous is inserted. Remember, intraosseous can be put in adults as well as in pediatrics. It is used for a vascular access when there is no IV available, or emergency situation like burns. A patient who comes for burns and you have to give, all of you must have studied in surgery Parkland formula. If there is no IV, what is the point of studying that whole Parkland formula? Which questions are asked, right? You first need to take an IV cannula for a burns patient, and only then you can give all the Parkland formula ka fluids. Now, so if there is no IV available, everything goes into waste. So if you don't have an IV available and it's an emergency situation, you need a rapid vascular access. Here is where you will put intraosseous cannula. The most common site that we use is tibia. It can be the proximal tibia or the distal tibia. Apart from the tibia, you can also use the femur, anterior superior iliac spine. Then there can be humerus and sternum. कहीं से भी inject करो. Remember, it's like an IV cannula, so you can give medications from there. You can give blood from there. You can give fluids from there. This is helpful to save someone's life. But because you're near the bone, it can cause fracture, right? Especially in child, it can cause fracture. There can be extravasation, there can be compartment syndrome, there can be embolism, right? So there can be fractures, compartment syndrome, extravasation, embolism, right? So this is your, Dr. Noop says, intraosseous route done after CPR after the first DC shock. हाँ, मतलब wherever you don't get an IV cannula is where you can use intraosseous. Correct? That's an important question. Which of the following test is being depicted in the image? Okay, the next question. Which of the following test is being depicted in the image? A. Correct. All of you are right. Right. But it is difficult because all the other tests that you see here are basically done in orthopedics. But when it comes in question in the exam, it will become difficult, right? So for carpal tunnel and thoracic duct obstruction, it is used for that. Thoracic outlet syndrome, basically. All this is where it is used. So Allen's test, remember, it is done to check the patency of the radial artery when you're putting an arterial line. In anesthesia, when we're putting an arterial line, remember it has to get filled up in less than 7 seconds. Right? Arterial line is this. You put it in an artery. And why is an arterial line inserted? Remember, it is used for invasive blood pressure monitoring. You don't inject any medicine here. It's an artery. Invasive blood pressure monitoring used in critically ill patients, ICU patient, when you want to measure beat to beat blood pressure. And also it is used for arterial blood gas sampling. Clear? ये भी हो गया. Done. Arterial line. Identify the device shown. Nebulizer mask, anesthesia face mask, Venturi mask, non-rebreathing mask. Okay. I think all of you are giving correct answers. Okay, no doubt about it. Everyone is correct most of the time. एक दो इधर लग रहा है मुझे, but most of you are correct. एक ऑप्शन एक जगह गलत है, otherwise all of you have mentioned correctly. It's a Venturi mask, right? Colorful. अच्छा, इसके लिए बोला colorful. ठीक है. This is not a non-breathing mask. It's a Venturi mask. Okay. This is what is a Venturi mask. It's based on the Venturi principle. All right. तो एक और देख लेते हैं. रुक जाओ. So when you speak of these devices, guys, these are oxygen delivery devices. Oxygen delivery devices basically are of two types. You're supposed to know. All of them are asked in the exam. These ones which you see, these are basically called as low flow devices. Low flow devices, you have nasal cannula, nasal prongs, which also call it nasal prong. And this works between 1 to 6 liters. And at 6 liters of flow on the flow meter, it gives a maximum of 44% oxygen. So FiO2 maximum that goes to the patient is 44%. Okay. There is a formula to calculate it for nasal cannula. For nasal cannula, the formula is, so these are all low flow devices we are talking about. These are all low flow devices. All of them. All these devices are low flow. Formula for nasal cannula is 21 plus 4 multiplied by flow rate. Okay, that's for nasal, only for nasal cannula, not for others. Then comes a simple face mask, which you also called as a Hudson mask. You can also call it as a Hudson mask. This works between 5 to 10 liters, and at 10 liters, it provides you oxygen of about 60%. In that case, if you attach a reservoir bag, there's something called as a partial rebreathing mask. It's before the non-rebreathing. Partial rebreathing mask will give you around 70%. And the last one which you see is basically a face mask plus a valve plus a reservoir. It's a face mask plus the valve plus the reservoir which you see from here. This is what is called as a non-rebreathing mask, the one which was used so much during COVID. NRBM, this works between 12 to 15 liters, and at 15 liters, it gives about 90%. So remember, out of all the same question can be asked like this: out of all the low flow devices, which gives the maximum oxygen? So this will give you around 90%. Remember, through anesthesia face mask, it is connected to the anesthesia machine, not this one. If you have an anesthesia face mask connected to anesthesia machine, it can give 100% also. Venturi mask maximum is 60%. Okay, so this is Venturi mask. Venturi mask is not a low flow device now. Low flow devices are nasal prong, simple face mask, partial rebreathing, and non-rebreathing. The others are high flow. This is a high flow device. The first one which you see over here, this is high flow nasal cannula. You can identify it in the exam by the presence of this device, which is humidifier. This gives warm and humidified oxygen. Presence of the humidifier by which you can identify the high flow nasal cannula. At 60 liters, it gives 100% oxygen. Again, used very much during the COVID. Another high flow device. So this is a high flow device which we just saw. And the other high flow device is the Venturi mask. Venturi mask is also considered as a high flow device. But more importantly, we call it as a fixed output device. Till now, all other devices we think can give maximum this much, that much, but we don't know how much. I can say nasal prongs 44, simple face mask 60, non-rebreathing 90. But I don't know exactly if it is going or not. In a Venturi mask, you know exactly how much what is going. You put a green one, you know it is 60%. You know, you put a red one, you know it's 40%. That is why it's called a fixed output device. Reason is because it works on a principle which is called as Venturi principle or Bernoulli's law of physics. What it does, we don't go into details, it causes something called as air entrainment. Air goes inside, so oxygen is going from here and air goes from here. So it's called air entrainment that takes place. We'll not go into so many details, not needed, but just remember the maximum here is 60. Though it's a high flow device, the maximum here is 60. Okay, so this is what is high flow device. So the classification of oxygen delivery devices are high flow and low flow. So most of the ones which you see with the mask are low flow. The only Venturi mask which you see is because of high flow, and another one is high flow nasal cannula where you see a humidifier. Okay, next question. 22. Which of the following is not an indication to use the following equipment? As you can see, we have discussed just the image-based ones. Huh? So which of the following is not an indication to use the following equipment? So you need to first identify what is the equipment, and then what is the answer? Very nice, Dr. Gaurav, Dr. Naveen, Dr. Rohit. Correct. All of you are correct. सबसे पहले पेशेंट को लगा है फेस मास्क, राइट? एंड फेस मास्क में पेशेंट हैज टू बी अवेक, so therefore unconscious patient is not a indication. Correct, right? Face mask is not an patient has a face mask. So what are we discussing about? This device is basically a CPAP or a BiPAP. All right, so this is basically non-invasive ventilation. So when you speak of the grading, right, if a patient comes in emergency, what is the grading of oxygen delivery devices or oxygen devices? We can write like this: nasal prongs or nasal cannula. After that, the next one which will give is the normal simple face mask. Then you have a partial rebreathing mask. Then you have a non-rebreathing mask. After that, you get a high flow nasal cannula. Then is your non-invasive ventilation that is given by a face mask. And here you have two of them, CPAP and BiPAP. After that, the next step is basically invasive ventilation. Invasive ventilation can be given by after putting an endotracheal tube or by doing tracheostomy. And once you put a patient with endotracheal tube and tracheostomy, this patient has to be put on ventilator. That is how you take care of casualty in a patient when he goes to the ventilator. Okay, that's how it is done. This is the grading of the oxygen supply by each of them devices which you see. Right, so nasal prongs, face mask, partial rebreathing, non-rebreathing, high flow nasal cannula, non-invasive and invasive ventilation. So this is an example of non-invasive ventilation. And remember, in non-invasive, I'm giving it by face mask. And because I'm giving by face mask, my patient has to be awake and spontaneously breathing. That's a prerequisite. Patient has to be awake and spontaneously breathing. Correct? Now, is it used for obstructive sleep apnea? Yes. Is it used for treatment of high PCO2 and low PCO2? Yes, because that is how it is used. If someone's CO2 is high, this device will help decrease it. Also, it helps to prevent hypoxia. So no doubt the uses is in case someone is having obstructive sleep apnea and non-invasive ventilation. When will you give non-invasive ventilation? If someone's PCO2 is high, that is the use to reduce the PCO2. If someone is hypoxic, you will want to increase the oxygen. So therefore, these are the uses. Okay, so the correct answer is unconscious patient. What are the contraindications? What are the contraindications of non-invasive ventilation or CPAP or BiPAP? So the contraindications are basically this unconscious patient or sedated patient and fracture to the face. So unconscious patient, sedated patient and fracture to the face. If someone has a facial fracture, how can you attach the mask? Clear? So we are done with this question also, right? Next question. During resuscitation, a patient is kept in the following position as shown in the image. It indicates which of the following? Unconscious patient, pulse and breathing absent. Unconscious patient, pulse and breathing present. Unconscious patient, pulse present, breathing absent. Unconscious patient, pulse absent, breathing present. Yes. Confusion. The exam question almost like this. So most of you have given the correct answer. Absolutely correct. Most of you are absolutely correct. The answer is B. Correct. Unconscious patient, pulse and breathing present. In CPR, you will keep this patient in this position, which is called as the recovery position. Recovery position. Okay? That's the recovery position. Correct. All of you have given the correct answers. Next, the adjoining image indicates which maneuver? Inline stabilization, jaw thrust, helix maneuver, head tilt, chin lift. Okay. Yes, the adjoining image indicates which maneuver. Is it inline manual stabilization? Is it jaw thrust, helix maneuver, or head tilt, chin lift? Correct. I think all of you already know it. Easy question. This has been asked in the exam, but yes, CPR points are important. Yes, head tilt, chin lift is absolutely correct. Okay. Okay. ECG during CPR shows the following rhythm pattern. Okay, correct. What I'll do is I'll finish off this question and I'll discuss the CPR in short. ECG during CPR shows the following rhythm pattern. The next appropriate step should be synchronized cardioversion, defibrillate, adrenaline or amiodarone. So you need to first identify what the pattern is. Or what should you do in a pattern like this? Correct. Most of you are correct. So I think most of you have given the answer B. You will defibrillate. Okay. So when you get something like this, ventricular tachycardia, remember this is CPR is being done. So if you get a pulseless ventricular tachycardia or ventricular fibrillation, the answer is defibrillate. You can't identify the R wave. Synchronized cardioversion is done when you can identify the PQRS complex. so that you can synchronize with the R wave. Are you sure about here? Where is the R wave? Correct. नहीं, sawtooth is atrial flutter. Dr. Gaurav, sawtooth is like this, atrial flutter वैसे आता है. That is what is called sawtooth. This is ventricular tachycardia fibrillation. You will see it's kind of fibrillating, right? Or you can call it as pulseless ventricular tachycardia going into fibrillation. All right, fibrillation यही होता है ना, ventricles are fibrillating. Normally polymorphic or monomorphic होता है. So it will be like this. If you get a proper rhythm like this, you get, okay, so this is what is called again ventricular tachycardia, but all the things are coming similar, right? So that's how we classify into monomorphic and polymorphic, right? Now here basically what you're going to do is defibrillate the patient. ADR and amiodaron is out, right? CPR is already going on. That's the rhythm pattern. So therefore you are going to defibrillate for this. Correct. Polymorphic, correct, right? Had they been given magnesium, you could have still thought about it, but still before magnesium, the answer is defibrillate. That's later on. Okay. Question number 26. Same image. A 56-year-old is undergoing CPR with the adjoining rhythm. Next step. You know, that's how questions come in the exam. We have kept the same rhythm, right? Based on that, now you give the answer. What is there? What are you supposed to do? I'll just discuss the CPR in short then. Yes. Very nice. I think all of you have got it correctly now. ठीक है. Remember, यहाँ पे point ये था exam में पूछने के लिए कि whenever you give a shock, remember immediately check pulse is wrong. Okay? नहीं, it's wrong. Dr. Naveen, no, correct नहीं है. After the shock, you never check for pulse. Immediately resume CPR. That's the answer. After the shock, continue or resume the CPR. So when you talk about CPR, I'll just discuss in 10-15 minutes, short mein, right? What is CPR and how it's done. Remember, this is what is the CPR chart. I'm discussing the 2020 guidelines because 2025 guidelines are not yet out. I have not seen them yet. Okay. So 2020 American Heart Association BLS guidelines. The first step is scene safety. Ensure scene safety for the rescuer, victim, and take standard precautions. Second step is check for response. If the patient is not responding, your third step is call for help. Call for help means you ask the people to come so that they can get a defibrillator, they can get, intubation trolley, they can get laryngoscope, eye gel, LMA to save someone's life. They can get the drugs, IV cannula, intraosseous cannula. Hence the third step is call for help. First is scene safety, second is check for response, third is call for help. Till now you have not checked the breath and pulse. The fourth step is where you check for the breath and you check for the pulse together. Simultaneously, you will check for breath and pulse at the same time. How do you check for the breath? You check for the breath by looking at the visible chest rise of the patient. You can see the chest going up or down. At the same time, try to feel for the pulse. Where will you feel for the pulse? Carotid. Adults, you will feel the carotid. You can also try the femoral. And remember, in pediatric patients, brachial can be used. Right? You will get three scenarios. The first scenario which we had just seen, that a patient's pulse and breath both are present. So scenario number A is that patient's breath present and pulse present. Nothing. This is what we had seen. Keep the patient in recovery position. Scenario number B, patient's breath is absent and pulse is present. Scenario number B is the patient's breath is absent and pulse is present. So what are you supposed to do here? Because breath is absent, you are going to give breath to the patient. How many breaths? 10 breaths. And remember, here it is said, you have to check pulse every 2 minutes. Right at the beginning, they've said, whenever you check for pulse, do not check immediately. The whole CPR, check pulse every 2 minutes, right? If there is sign of opioid overdose, you can give naloxone if you think. Otherwise, just give breath and keep on checking pulse every 2 minutes, right? The third scenario is, this is scenario number C. When the breath is absent, when the pulse is absent, you go to the start CPR. Now, when you start CPR, this is my fifth step, which is I have to give CPR, chest compression, airway, and breathing. This is what I'm supposed to do. First was scene safety, second was check response, third was call for help, fourth was check breath and pulse. You got three options. One, both are present, recovery position. Breath absent, then you just give breath, and when both absent, you give start CPR. Chest compression, airway, breathing. So when you give chest compression, remember the first thing is chest compression, the second one is airway, third is breathing. Chest compression, where do you give it? Lower 1/3 of the sternum, both adults and pediatrics. 100 to 120 per minute is the rate. The depth, again exam question, 2 to 2.4 inches or 5 to 6 centimeters. They've asked this many times in the exam. And always allow chest recoil, let the chest come back. Correct. Airway, airway means you have to open the airway, right? So therefore what you're going to do here, maneuvers. Therefore you're going to do the head tilt, chin lift, or you can also do jaw thrust. Remember, head tilt, chin lift is contraindicated in fracture cervical spine. So therefore in fracture cervical spine, the better to do is jaw thrust. Jaw thrust. So what is jaw thrust? So normally head tilt, chin lift is done like this, where you do a head tilt, chin lift, and then jaw thrust is when you lift the jaw up. So this is what is called as jaw thrust. The next one which you see over here, this is what is called as jaw thrust, where you lift the jaw up. This is jaw thrust, right? And that is done in fracture cervical spine, because you cannot do head tilt, chin lift. If you are suspecting a fracture cervical spine, it is contraindicated. All right. So therefore, head tilt, chin lift is contraindicated in fracture cervical spine, and that is where you prefer to use a jaw thrust in fracture cervical spine. Also, if there is a vomitus or foreign body, you need to remove it out. Then you give breath to the patient. Same way, breath is given mouth to mouth breathing, mouth to mask, bag mask breathing, right? Don't give no excessive ventilation. Around 2 breaths are given. 2 breaths, always give 2 breaths at one time, and always look for a chest rise. What are you supposed to do now? Combine all of them together. You're supposed to do cycles of 30:2, right? That's the next step. Our 5th step was start CPR. Remember, start CPR, we did chest compression, airway, breathing. You are supposed to do cycles of 30:2, cycles of 30:2, and you will continue doing this for 30 to 40 minutes till the time advanced life support people are there, or if the patient gets revived. When you get other people coming to help you, or you get a defibrillator, that is my point number 6. As soon as you get a AED, because you're outside, you don't have a defibrillator. So you have a AED. It is a device which is automated. It is called automated external defibrillator. Automated external defibrillator. Here you don't have to do anything. You just attach the pads. If they say rhythm shockable, yes, give the shock. After the shock, remember, straight away resume CPR. Important point, no pulse check. This is the exam question. After the shock, immediately resume CPR. And what was the CPR? Cycles of 30:2. You'll keep on doing this for 30 to 40 minutes, right? If the rhythm is non-shockable, no shock. No shock means straight away resume CPR. And again, you will keep on doing for 30 to 40 minutes, right? So remember, every time you are resuming CPR, you will be doing the CPR for 2 minutes, and every 2 minutes is where you have to check the rhythm again. Every 2 minutes. That's what has been said. Every 2 minutes, right? Every 2 minutes you will check the rhythm. If the rhythm is shockable, you will give a shock. After that, no pulse check. Do it for 2 minutes. Again, check the rhythm. Same thing happens in non-shockable. When there is non-shockable, no shock is to be given. After the shock, straight away CPR. Continue for 2 minutes, and again check the rhythm. That is what goes on for 30 to 40 minutes. What is the difference between BLS and ALS? In BLS and ALS, the difference is now you have got a defibrillator where you can decide it is monophasic, biphasic, how much shock you're going to give. The quality of chest compression is better. You can use drugs. Intravenous, intraosseous line is available. So epinephrine or adrenaline, amiodarone, lignocaine, and magnesium can be used, right? You can use endotracheal tube or laryngeal mask airway. You can use capnography to confirm, correct? You are monitoring the patient. So endotracheal tube is there, supraglottic airway device or LMA is there. You have capnography by which you can confirm that your endotracheal tube has gone in correctly. You can monitor by pulse, BP, right? ETCO2, all that. In between, you can keep on thinking about the 5H and 5T. What must have happened to the patient? This is how you manage the CPR case. Okay? Last point. Remember, this was a question on which a question came in INI-CET also. A question came in FMG also. This is what is called as chain of survival. Chain of survival are the sequence of events which are joined together to save someone's life, which give you the maximum benefit to the patient in saving the life of a patient. So the first thing is in hospital cardiac arrest. INHA means in hospital. If a cardiac arrest has happened inside hospital, the first thing is try to recognize, that's the first point. Try to recognize that it is cardiac arrest and immediately call for help, activate emergency response, do a high quality CPR, which means good chest compressions, 100 to 120 per minute, all that we were discussing. Defibrillate when as and when needed. If it is ventricular tachycardia or ventricular fibrillation, you will give the shock to the patient. That's the fourth step. Fifth link is post cardiac arrest care, and the sixth link is recovery. Remember, when we speak of out of hospital cardiac arrest, means now the patient is not in the hospital, patient is outside the hospital. Here, fifth and sixth link remain the same, but first four are slightly different. So if it's an out of hospital cardiac arrest, immediately call someone for help, emergency response. Immediately call for help. That's the first thing. Ensure a good quality CPR. So this comes over here. High quality CPR is over here. Defibrillation is over here. More important, this is out of hospital. So you have to take the patient to the hospital as early as possible. Get an ambulance and advanced resuscitation has to be done. This is the fourth. So normally they will not ask you 1, 2, 3, 4 because they are different in hospital and out hospital. And both in FMGE and INI-CET, the questions asked were about the fifth and the sixth point. So the fifth point is post cardiac arrest care when the patient is safe, and the sixth point is recovery. So therefore the fifth point is post cardiac arrest care. So in the fifth point, which is post cardiac arrest care, what are we supposed to do? In post cardiac arrest care, now the patient is revived, patient is in the ICU or in the hospital. So both the points post cardiac arrest care will involve that you need to ensure that the BP is normal, ensure that, so try to maintain, you can't be sure, but try to maintain the SpO2, try to maintain the blood sugar levels, try to get a neurological assessment done as fast as you can, so that you can intervene if needed. You can do a cardiac cath lab, you can take the patient over there, maintain the temperature of the patient. That is what is called as post cardiac arrest care, and recovery means rehabilitation, as correctly said by Dr. Gaurav. Okay, so these are the fifth and sixth points of the chain of survival, and fifth and sixth points have been asked. The fifth was asked in INI-CET exam, and the sixth was asked in FMG exam, this time January. Okay guys, so that was from my end. Okay, I tried to finish off whatever points were there from anesthesia. Thank you everyone for joining me. You can take down my Telegram ID. My Telegram ID is Instagram ID. You can follow me on Insta also. Instagram ID is dr.vinish, Vinish. Whatever MCQs I put on Instagram, no one sees here. All of you are looking at my guitar videos and my dance videos. No one sees my MCQ videos. Okay, dr.vinish, you can search for me. Okay, on the Instagram. My Telegram also, it's not a group, but my Telegram ID is doctor without the dot Vinish. In both of them, you will have me. You will have seen me with a guitar. Okay, my photos there with a guitar on both of them. So Instagram is dr.vinish, Telegram is Dr. Vinish. Okay. Any questions and doubts, you can ask me there also. I'll try to solve them to the best of my knowledge. Any questions right now, you can ask me. Okay, so thank you, Dr. Marshallits. I know I took it long. I did not give a break also in between, and all of you were sitting. Dr. Mahesh. अरे इतना अच्छा नाम है डॉक्टर महेश. अच्छा ऐसे बना के रखा है Marshallits, ठीक है. And thank you Dr. Mahesh. Dr. Mahesh, thank you so much. Okay, so I shared my Instagram and Telegram also with you. So any questions and doubts, you can ask me. Dr. Rohit says, can you explain briefly about MAC? So what do you want to know about MAC, Dr. Rohit? It's a big topic here. MAC में जानना क्या चाहते हो? What is it that you want to know? And gas solubility. Dr. Tasmina says, thank you. Concept clear हुआ. Thank you Dr. Tasmina. Of inhalation. No, I got it, Dr. Rohit. लेकिन Dr. Rohit तो बहुत बड़ा topic है. What exactly would you want me to tell you about it in short? I'll let you know. Dr. Anokhi says, next video. Next video मतलब अभी के लिए कि आगे के लिए? डॉक्टर रोहित का पहले क्वेश्चन थोड़ा सॉल्व कर दिया जाए, ठीक है? The order of potency, right? Okay, so you want the order of potency, and we'll discuss the order of blood gas solubility. Correct. Okay, Dr. Rohit, done. I understood the point. That's what I wanted to ask you. What do you want to, because it's a very long topic, yeah. So let me just discuss with you the order of, remember, let's discuss just exam point of view without going to details of understanding the concept. Remember, minimum alveolar concentration is inversely proportional to potency, which means if a drug value is more, it is less potent. If the value is less, it is more potent. Okay, and here remember, you can methoxyflurane. Okay, methoxyflurane is the most potent agent, right? And on the other hand, you'll find nitrous oxide to be the least potent agent. You can remember it like this. Okay, so this is the most potent, then is halothane, isoflurane, sevoflurane, desflurane, and nitrous, not potent. And I can use the same thing to understand the blood gas solubility also. Okay, so methoxyflurane, halothane, isoflurane, sevoflurane, desflurane. And if I have to talk about blood gas solubility, so blood gas solubility, remember, it is also inversely proportional, but is inversely proportional to onset of effect and recovery. So this was minimum alveolar concentration inversely proportional to potency, and blood gas solubility inversely proportional to onset and recovery. I will use the same thing. Let's use the same thing. So methoxyflurane, halothane, isoflurane, and sevoflurane remains the same. But after that, you can change it slightly. Dr. Mahesh says, Dr. Mahesh says, we have to remember the MAC, or it's given. No, don't remember the MAC value. That's what I said. Don't remember the value. Just remember this order. So methoxyflurane, halothane, isoflurane, sevoflurane. एक change बस हो जाएगा यहाँ पे between desflurane and nitrous. That first you will get now nitrous and then you get desflurane. But this is the only change that takes place, and it will become like this. Okay. And if you want to add, especially for INI-CET, desflurane के आगे आता है xenon. So you will find that methoxyflurane inverse है ना, so methoxyflurane is slowest onset and recovery, and xenon you will find as the fastest onset and recovery. Okay, xenon is the fastest onset and recovery. Clear? So you just need to remember the order. तो यहाँ पे तो देखो order same है ना, ये methoxyflurane, halothane, isoflurane, sevoflurane, ये यहाँ तक same है. It's the same, all right, for both of them. It's just that methoxyflurane most potent. There's another way to think about it. Remember, most of the time it's not true. Both are separate properties, but for exam purposes, remember the most potent agent normally is the slowest onset and recovery. Normally, and the least potent agent, okay, the least potent agent is normally the fastest onset and recovery. And in anesthesia, we prefer to use the drugs which have fast onset and recovery, right? So that is why the point is you don't get to hear methoxyflurane being used, halothane being used, and nowadays everywhere you find drug of choice is sevoflurane and desflurane, right? You will not find these drugs being used, right? Slow onset drugs are not preferred, though they are more potent, but we don't want more potent drugs. Our point is we need fast acting drugs. Okay. Dr. Gaurav says we'll ask least or most potent. Yes, that's what they will ask you. They ask you the order also, the arrangement of orders. Please arrange them in a sequence. So don't need to remember, you guys don't need to remember individual numbers. Always remember another point. MAC जो होता है, it's always given in percentage. For example, methoxyflurane का जो value होगा, that will be given as 0.16%. Nitrous oxide का value is going to be 104%. Halothane का value will be around 0.75%. So you will always have this percentage written at the end in case it is a minimum alveolar concentration. On the other hand, for blood gas solubility, it is just a number. For methoxyflurane, the number might be 15, right? And for desflurane and sevoflurane, it can be 0.4, around 0.4, right? So don't have to remember the numbers. It's difficult for you guys to remember the numbers. You people are not supposed to know that. But yes, the order, the sequence is important. which one is more potent, less potent, least potent. And as I said, just remember the ones which are most potent. Not an exact correlation, but just to remember for exam purposes, the most potent ones are slowest onset ones, and the less potent ones are the fastest onset, right? That's how you can remember. Okay, this was in short. I'm not saying this is the proper concept, but this is just for last minute exam purposes that you just need to remember and go for the exam. Okay. डॉक्टर अनोखी से सर ये लेक्चर रहेगा ना यूट्यूब पे, आई ज्वाइन एट द एंड. हाँ हाँ रहेगा डॉक्टर अनोखी, करेक्ट रहेगा, रहेगा रहेगा यूट्यूब पे रहेगा. मैं नहीं निकाल रहा हूँ, वी आर नॉट टेकिंग इट ऑफ. ओके, डोंट वरी. Otherwise, you have my Insta ID and Telegram ID. You can follow me on Insta and ask me questions directly on Insta, guys. Okay? Don't worry if you join at the end. Any other questions and doubts? डॉक्टर रोहित का फिर डाउट क्लियर हो गया? डॉक्टर रोहित का डाउट क्लियर? और किसी का कोई डाउट? Anyone else, guys? Otherwise, then we'll stop the session. Thank you for joining me here. Thank you. Three hours we sat continuously, right, without a break. Hats off to all of you. I was sitting and just trying to talk, so for me it's easy. But for you to be sitting at one end and listening continuously for 3 hours is not easy, right? And all of you were interactive all throughout. All of you kept on texting me also. Message karte rahe tum log. Thank you. So I'll take your leave, guys. Okay. Thank you, guys. So that's my Insta, Telegram, and see you later. All the best, guys. Do well. All the best to all of you. All the best. Do well. God bless. Thank you. Thank you, Dr. Mahesh. Thank you, Dr. Gaurav. Thank you so much. Okay, chalte hain. Hopefully we'll plan another session here. Try karte hain. Let's see if it's possible. We'll try to have a small revision also. I think that is fine. We'll try to do a complete short revision. Let me just discuss things out. You guys just follow us. If कुछ भी होगा तो we'll let you know. ठीक है? So thank you everyone. Thank you. Thank you, Dr. Tasmina. Thank you, Dr. Gaurav. Thank you, Dr. Mahesh. Thank you everyone for joining me at this session. Thank you and all the best. Do well. Chalo. Good night. It took a lot of time. 3 hours. Bye bye. Good night.